Good evening, everyone. I am Dr. Manjula from Fever Foundation. It gives me immense pleasure to welcome you all to this evening scientific session on behalf of Fever Foundation. Fever Foundation is an educational and non-commercial foundation catering to educational and academic activity to address the unmet needs in fever management. The foundation is committed to conceive, build, and sustain programs and make scientific initiatives which are aimed at providing evidence based update to the healthcare profession. The vision of Fever Foundation is to strive towards imparting knowledge on the unmet needs and provide information on research, education, and therapy updates on fever management. So some of the activities of Fever Foundation, we conduct annual fever conferences. Already we have completed 5 such conferences, which is attended by physician, pediatrician, intensivist, infectious disease specialist, oncologist, all people who manage fever, including family physician, come under one roof and then discuss about various issues, aspects of fever management. Then we conduct fever CME throughout the year, and we bring about book on fever management after every conference, one for pediatrician, one for physician. And Fever Foundation support clinical and epidemiological research. And we have a few activities for postgraduates in medicine and pediatrics, challenging case presentation competition for PGs in medicine and pediatrics. We have a quiz competition for PGs. We have poster presentation competition for postgraduate students. Young Scholar Award, and also we conduct lot of educational activity, public awareness, patient education, paramedical education, parent education, and public awareness activities. So now we are celebrating the Fever Week starting from yesterday, 24th May to 30th May. This is to commemorate the birth anniversary of Sir Daniel Gabriel Fahrenheit, the inventor of thermometer. On this occasion, Fever Foundation is conducting several scientific activity. One is national panel discussion. Yesterday, we started with a panel discussion on errors in fever management for pediatrician, 24th May. And today, we are all here for errors of management in managing adults, which is for physicians and family physician and general practitioner, infectious disease specialist, intensivist, all those who manage adult patients, which is today. Then apart from this, we have several CME programs. We were planning to do 100 programs this week across India on several cities across India on fever and its management. And we are also conducting this week patient education, public awareness activities through FM radio. So every day, our eminent advisory board members will be taking part in this educational activity. So today, as I mentioned, we are here for a very, very important scientific program, Common Errors in Fever Management. I'm sure all of you would find it very, very interesting because this is the topic which you will be finding it in your day-to-day practice. So that's why this topic has been chosen. And to conduct this panel discussion, we are fortunate to have eminent doctors with us. I have the privilege and the pleasure to introduce our moderator, Dr. A. Muruganathan sir, Director-elect, Physician Research Foundation of API, immediate past Governor, American College of Physicians of India Chapter, ex-emeritus Professor, the Tamil Nadu Dr. MGR University, Dean, Indian College of Physicians, and past President API. Sir, it's a pleasure and privilege to welcome you, sir. We have our panelists who will be part of this important discussion. We have Dr. T.S. Ravindra sir, Head of Department of Medicine at Mallige Hospital, Bangalore. Dr. D. Suresh Kumar sir, Senior Consultant Infectious Disease Physician at Apollo Hospital, Chennai. He's also co-founder of Best of IDs, the Doctor's Doctor, and a very popular WhatsApp Best of ID group. Then we have Dr. Anupam Prakash sir, Director, Professor of Medicine and Head of Department of Accident and Emergency at Lady Hardington Medical College and Associate Hospital, New Delhi. And we have Dr. Binita ma'am, Director, Professor of Microbiology at the University College of Medical Sciences in Delhi. And it's a pleasure and a privilege to welcome you all also. Sir, it's now handing over to you, Dr. Muruganathan sir, to conduct the proceeding and take the session forward. Over to you, sir, Muruganathan sir. Thank you all.
Thank you very much. Good evening, dear brothers and sisters. it gives me great pleasure to meet all of you, more than 3,000 to 4,000 people across the country, on a very important day-to-day problem. In fact, the Fever Foundation, we were discussing uh, what should we do, and nobody recognized the Fahrenheit. We always worried about centigrade. So we thought this Fahrenheit person who has invented Fahrenheit, we should celebrate his birthday, not one day, because everybody celebrates one day only. Now we are to celebrate his birthday as a fever week. And we are also very proud to announce we were the one, the Fever Foundation started exclusive fever for 2 days conference, etc. Because even from before COVID, we started. Only after COVID, all over the country, people started fever clinics and fever screening, etc. But we were wise enough to start much, much earlier, 7 years back. Now, I'm going to ask questions from all the panelists. We have got a good clinician, a good professor, a good infection specialist, good microbiologist. So I will, divide my questions from history taking, physical examination, investigations, and management. See, normally, any case, we'll have to have first history. History is very important in fever also. I think Suresh has come. Suresh, tell me, what are the most common gaps in history taking by general practitioners in fever case?
So good evening. First of all, I thank the Micro Labs for giving this opportunity and Fever Foundations for inviting me for this panel. And I thank the chairperson for kind words of introductions. So before I start, the most important thing in clinical medicine is history taking. As far as fever is concerned, history is the most and single most important thing. Most of the time, we don't use a stethoscope also. We take proper history and we can able to figure out what is going on. If you see the Hostler code, if you listen to the patient tell the diagnosis. Unfortunately, we are not listening. That's a problem. So most of the time, we need to listen to the patients, what he is telling, particularly in respect to the fever. Patient will tell all the things. We need to only guide the patient. Some patients can deviate, but we need to guide the patients regarding the history taking, particularly whatever the symptoms. For example, fever means we need to dig what is the durations of the fever, what type of fever is having, what medication release and what medications provoke the fever one. And second thing, the most neglected part as far as a thing, patient's personal history or travel history or social history. For example, when a patient has got a short febrile illness, cough and cold, the next thing I should ask is what is a sick contact? Anybody in the family, anybody in the office, anybody travel? If the patient gives somebody sick in the family, he got fever, cough and cold, automatically this is ILI or influenza-like illness to me. Similarly, when the patient is a young patient, if he's going to out, taking food, outside food, particularly whichever food is not cooked, not boiled, then we think about typhoid because the fever is crossing more than 5 to 7 days. The patient is eating outside food and fever is not coming down. The fever is going behind 5 to 7 days. That is why we need to dig the history, particularly the personal history, travel history, social history, along with detailed examinations, whatever he whatever the symptoms and whatever symptoms he's suggesting to me, I need to do a detailed physical examinations based upon the history what I'm getting it. Unfortunately, the history part is the most neglected part. If we listen to the patients, we can able to get it. The patient is not giving a proper history. We need to guide the patients to get the proper history from him there.
Thank you, Suresh. I think, even for example, scrub typhus, if somebody has gone to Northeast, then we can find out. Also, one more history, the Suresh, drug history. Some people have take drugs and that also can cause fever. Continuing the history, Dr. Ravindra, please tell me what errors do GPs commonly make in interpreting the duration of fevers and its importance?
Duration of fever is one of the most important parts of history taking. The common mistakes are that the first 3 or 4 days, it's an undifferentiated fever unless there's, of course, clinical signs like, for example, tonsillar infection or for that matter, rash, a viral exanthema or something like that, usually due to influenza. Unless patient, like Dr. Suresh said, is eating out and having upper GI symptoms or something like that, duration is very important. Now, many people underestimate the duration of fever because low-grade fever may not be noticed by the patient, number one. Number two, feverishness, that is body ache, feeling of having fever without rise in body temperature may be misjudged. Again, fever comes on and off. Then patient says, sir, I had fever for 3 or 4 days, then it went off. And then again, it was not there for 3 or 4 days. You underestimate the duration of fever. Now, duration of fever is very, very important in certain important conditions. Like, for example, continuous high-grade fever going on for 7 days, patient eating out, not eating proper in a hotel, may have typhoid fever. Now, the same thing, you put it across, that patients have duration of fever lasting more than 2 weeks. The first diagnosis you can rule out straight away is dengue fever. Dengue fever does not last for beyond 2 weeks. Longer periods of fever may be difficult to diagnose. And one of the important things is tuberculosis and HIV. Now, fever for 2 weeks, then absence of fever for 1 week may be present in patients with, say, Hodgkin's lymphoma, typhoid relapse, patients inappropriately treated for LRTI, and also important drug-resistant UTI. Yeah. So these are the common things that you have to think about when duration of fever.
Thank you, Ravindra. So now, in the history taking itself, so many informations you can get. Because you gave a clue, I'll come to Anupam. Anupam, Ravindra was saying, people feel feverish and take medicines. How far it is justified? In other words, what temperature or what fever should be treated, and what conditions or illness can mimic such feverishness? You unmute, Anupam, please unmute.
Sorry, am I audible, sir?
Yeah, you are audible.
Thank you, Dr. Murugathan, sir, and the esteemed panelists. Yes, fever is a problem, and day in and day out, we face cases of fever. In fact, every day we have one or the other patient who is having a different kind of fever, or he poses a problem. And as Dr. Murugathan posed the question that what fever should be treated, so the yardstick may be different for us doctors, because we say that yes, fever should be moderate grade or high grade for it to be treated. But in clinical practice, the dictum is any fever that troubles the patient should be actually offered solace. That is what we are doctors for, and we should offer treatment to the patient. So at least fever has to be brought down. Obviously, simultaneously, we should try to find out the etiology also, the cause of the disease also, because otherwise fever will continue to be there. But yes, most of the times, any fever more than 100.5 or 101 degree Fahrenheit, that definitely will beget or ask for treatment, and antipyretics may need to be given in such patients. But yes, at times patients have a temperature of 99.5, 99.9, and still they feel a lot more weak and lethargic and are not able to do anything. At that time, we should not ideally ignore that. We should try to ensure that, yes, these are the persons who may not be requiring scientifically treatment, but yes, they have to be investigated. So people who may be on the upper limit of fever, at times patients are anemic, at times patients have a tuberculosis or lymphomas, wherein patients can have low-grade fever, and that may at times be missed, and we may not accord due importance. But yes, at that fringe is also, it is important patients who have symptoms and they report symptoms even within the normal range also. At times, we should be able to investigate them and try to find out a cause, not ignore them.
Thank you, Anupam. You have given a clue, investigations. Now I come to Vinita. In all fevers, do we need investigations? What are the challenges in diagnosis of common fevers?
So the challenges are many. I think, good evening, first of all, and thank you so much for this. Challenges are many. Actually, we should remember, we always forget that we are not treating the reports, we are treating the patient. So the most important challenge, I feel, starts from the clinical manifestations. As everybody has already said, protein manifestations, non-specific signs and symptoms, especially during the beginning, initial phase of the fever, there are so many non-specific signs and symptoms, and they are overlapping. So we really are in a desperate need of some clinical history or epidemiology or some background knowledge of the patient, first of all. Then diagnostics are, if I start from the gold standard, also the main gold standard diagnostic technique, which is of culture. For many febrile illnesses, culture is supposed to be the gold standard from time immemorial, but culture has many limitations, prior antibiotic history, or even the timing of sample or kind of sample, or what is the volume of sample that we're using, plus the brief transient bacteremia that is associated with organisms like salmonella, the more commonest endemic infection, that is typhoid. It's such a brief transient bacteremia that we're not able to, the load also is so less that it is not being able to caught by the threshold that is existing for the current diagnostic tests. Then if we talk about, so gold standard tests failed miserably. Then if we talk about the commonest used tests are like serology, we all know the dynamics of serology, IgM, IgG, all these interactions is very complex to understand. In an endemic country like ours, we don't expect, the ideal situation would be we should have an acute and a convalescent sera, and then we are able to demonstrate fourfold rise, but that never happens, sir. So, coming to any conclusion after one single IgM reading or IgG reading becomes very difficult for us, because that could indicate reinfection in convalescence or vaccination, or we need to have a history of vaccination, previous history, etc. Then, sir, if we come to the advanced tools, then they have the limitations that obviously they are not present everywhere. It's not in every corner of our country. Plus, certain inherent problems of the bacteria itself. So for example, salmonella, it's an intracellular pathogen. So obviously, the kind of antigen expression, it is dynamically different and drastically different from what we get in vitro. So we need to know which are the best expressed antigens, or for example, muted ion that we have for a salmonella, or carriage, long carriage associated with salmonella. So these are some of the very big challenges that we face during the diagnosis of even a very common illness, which is prevalent in our country. So most of the challenges are these.
Thank you, Binita. I will come back to you because you have given an introduction. So one by one, we'll ask questions. Now, I continuing the history, Suresh. We talk about lifestyle modification, lifestyle factors in non-communicable disease. How relevant is the lifestyle, and what is the error the GPs make? Unmute, Suresh, unmute, please.
Yeah. So most of the time, we encounter the community-acquired fever in our OP settings, particularly the community-acquired fever compared to the hospital-acquired fever. Most of the thing it is related to the lifestyle, what the person is following it up. As I told earlier, the patient is traveling to the crowded places or gathering happening there and started developing some respiratory symptoms. We need to think about viral fever like influenza. Suppose young person, most of the time staying away from the home, eating outside food, think about typhoid. Suppose the patient is from a farmer background, agricultural background, standing most of the time in an agricultural field, the chances of leptospirosis is possible. Similarly, the patient from the suburban background, having a bushy, for example, he's got a lot of garden around his house, compared to the city that mostly flats only is there. Suppose the person from the suburban background, staying in a suburban background, staying with a lot of garden or a lot of trees, bushes around his place, then exposure to the scrub typhus is possible. In fact, my first diagnosis of scrub typhus in 2009, the patient is proper from the city. I was wondering, the guy was a lawyer practicing in High Court, and he was staying in a proper city of Mylapore with a 8-story flat that he was staying. So I was wondering where he got. Then we dig the history, what happened to him. Then he used to go to the morning walk in a park. After the end of the walk, he sits in the floor of the park, not on the benches. So he sits in the floor and he discusses with his colleagues for almost half an hour some difficult cases. So that history gave us to clue. We in fact went and searched where he got the bite there. But finally we got the history. The person went to the park and sit in the ground floor of the park and sitting with the colleagues and discussing for half an hour. There he got the bite. So this is how we don't dig the history. That is more important for us. So lifestyle is playing a very important role as far as community-acquired fever is concerned, by asking what are the things he's doing, what is his habits, and where he visits, where he travel, what he does, and as he rightly pointed out, what antibiotic also. Some prescriptions given by your previous practitioners, don't just ignore it. Just see the prescription. That is most important for me. For example, the prescription patient has received a cefixime. For example, the person has received cefixime. That is a good dose of cefixime. What I do after taking cefixime, the fever is persisting, the chances of leptospirosis is unlikely. He has taken 3 to 5 days of cefixime, means leptospirosis is unlikely. Suppose the person has taken doxycycline given by other practitioners, then what is unlikely? Scrub typhus is unlikely. Scrub typhus is unlikely. Leptospirosis is unlikely. Similarly, the person has taken azithromycin for 5 to 7 days. Still, the fever is going on. The chances of typhoid, lepto, scrub typhus, these are things ruled out. So we need to see the history of the previous antibiotics also. Focus the antibiotic history also. So not only the lifestyle, previous medication history is also very important. So we can figure out. Similarly, the patient is a diabetic. The diabetic, poorly controlled diabetic. The patient has got fever for more than 2 weeks and patient is from agricultural background. Think of milioidosis. TB is common diagnosis, people think. But milioid also come to the people who are poorly controlled, diabetic, rural background or semi-urban background, lot of field exposures, agricultural field exposures, think of milioidosis. So this is how the lifestyle,
that's why
medication is very important, sir.
Suresh, very important point is history taking is very, very important in diagnosis. I'll come to Ravindra. Ravindra, you're a senior person. Now people say I went and got drenched in rain and I did not properly dry my hair and then I got the fever. Do you agree about the history like this producing fever?
No. It is usually due to influenza like illness, which just because you got drenched and immediately started a fever is very, very unlikely.
Okay. Now, continuing the investigation, what is the common error physicians making when they write urine culture, blood culture, like that?
Now, coming to urine cultures, see, the first and the most important thing is only a fresh sample should be given. What happens is they take the bottle from my clinic, go home, pass the urine, and then about 4 to 6 hours later, when he might drop off the bottle. Now, this fresh sample it's not a fresh sample and is very, very unlikely to get a positive reply. Second, only midstream sample urine should be taken. This should be specifically told to the patient. Otherwise, what happens is they will just pass a little urine in the very beginning, close the thing and give it. The sample may be inadequate and it may be inadequate for testing. The third is when you take from catheterized patients. In catheterized patients, you tell the sister, take a sample for urine culture, and what happens is the patient simply takes from the bag, pours it from the bag and sends it for this one. One, it is not a fresh sample, and second thing, it is contaminated. So the result might be different. Fourth, we almost never ask women whether they are in menses before asking for a culture, urine culture. We just give it to the patient and say, do a urine culture. And then the lady comes back and says, sir, I'm having menses, should I do a urine culture? And you look like a fool. And the last one in urine culture is to interpret colony counts of between 10 and 30,000. Unless patient is specifically on antibiotics and there is a definite history of UTI, it may be misjudged as to what the actual diagnosis is. Third, and the last one is, and the most important, we have to ask a history of antibiotic use or abuse before you ask for a urine culture. Because if the patient has taken antibiotic for 2 or 3 days, and even though he may have symptoms of a UTI, his culture might come negative.
Yeah.
Shall I tell the blood cultures also?
I'll come to you later, Ravindra.
Okay, sir.
Before we go to Anupam, I think before you do urine culture, I think you'll have to do routine urine examination and see whether there is any pus cells, deposits, and then only we give urine culture. If the urine routine examination is normal, normally we don't need to send it to urine culture. If I am wrong, please stand me corrected, Ravindra.
No, you're right, sir.
Yes, okay. Now I'll go to Anupam. Anupam, you are talking about feverish and all that. And some people have high fever, but they don't feel any symptom. And what type of fever, we don't know. But do they require antipyretics, any treatment?
Well, people yes, you are right. This is a very common occurrence at times, and people will have temperature, but they will not feel it. That is body's own tolerance also. And some people are actually accustomed to it, and they will not fever if it does not cross 101 or 102 degree Fahrenheit. But yes, it is not right. That fever has to be investigated and treated also, because actually any rise in temperature increases the metabolic demands of the body. And even if the patient is not feeling that he has temperature, but if he is running fever, the body systems are under stress. So it is important to understand that yes, although the patient is tolerating well, but that cannot be ignored. And such kinds of fever, we should actually consider investigating them. Not necessarily that we bring down the temperature, but yes, if the patient is having comorbidities like anemia or coronary artery disease, where the fever per se increases the metabolic demands and can actually precipitate symptoms, we need to be very, very careful with these persons. And high fever or moderate fever, where the patient is not having symptoms, even in patients who don't sweat at times in this summers, heat stroke and heat exhaustion is also very common in these patients. And they may keep on roaming in the summer heat also, and they will not feel that they are having sweating, and they will not feel, and suddenly they will just feel exhausted. So we should not allow them to reach that break point, and we will need to treat these patients and investigate them accordingly, and then we
So,
can see
Anupam,
what
sorry
to
to
be done.
interrupt.
Yes,
Treat
sir.
the patient means what do you want to give?
See,
Antibiotics?
sir, we will need to take, as the panelists say, a history is very important. And when we do a physical
No,
examination,
my question, Anupam, if there is a high temperature, patient do not have any symptom, will you give antibiotic or not?
sir, antipyretics, I would say, if yes, as I said, if the patient is having distressing symptoms, then definitely you need to give. Otherwise, if the patient has comorbidities, then we should bring it down. But otherwise, not, because what happens is by bringing them down, we subject these patients to fluctuations of temperature. And in fact, that is much more distressing than a temperature of 100 or 100.5 per degree Fahrenheit for that particular person.
But
So
at
that is
least
my opinion.
at least will you advise hydration for these patients?
Hydration, yes, definitely. Hydration, rest, avoiding summer sunshine, that is very,
Okay.
very important. These are
Th-
things which are preventive, which have
Thank
to
you,
be
Anupam.
taken whether or not fever is there.
Thank you, Anupam. I'm going to have only short answer. Sorry, because we can cover more
Yes,
points on
agreed,
this.
agreed, sir.
Yeah, Madam Vinita, what are some of the emerging diagnostic methods or platforms on which emerging diagnostic discoveries are based on?
So besides the conventional that we all know about, there are many emerging technologies that are coming up in the form of the nucleic acid amplification tests are the most in news, and then biomarker search for biomarkers for corresponding to various stages of the infection by high-end technologies like microarray or mass spectrometry, etc. These are there. Then immunodominant antigens, the antigens which are expressed, we look for that. Multiplexing is very important and is being applied to a great extent. Multiplexing is being done in various ways. You can have multiplexing of various etiologies of one syndrome, like we have respiratory panel or meningitis panel or fever panel. Then we can have multiplexing of various genes of one particular bacteria, so that we come to the optimum diagnosis. We can even multiplex the resistant markers with the etiology, so that within a short span of time, we can know the identification as well as the resistance. So the whole idea is that you combine all these high-end technologies of NAT into and make them compatible with point of care tests. The test that can be done the test that can be done at the point where care is being given to the patients, and then develop.
I'll come to you about point of care later on, Vinita.
Yes,
I think, yes, thanks. Now I'll go to Suresh. Suresh, from the history, I would jump to physical examination. What are the most common physical examination errors physicians make when evaluating febrile patients, and how do these impact patient outcomes?
So the first and foremost thing is they need to record the temperature, particularly when the patients comes to you to the OPD. They keep claiming I got fever for 2 months, I got fever for 20 days, 25 days.
When you say the recording, what is the error they make in recording, either in the prescription or the case sheet?
They don't record the temperature. They take the patient's words as a belief, and they start writing the patient has got fever 25 days. But when a patient is stable, there is no localizing signs to me, no other symptoms except fever. Recent encounter, one 45-year-old female.
Suresh, again, recording temperature, what is the best method? under the
People
tongue
usually
or
always
armpit.
confuse us with the axillary oral temperatures, and usually the two sides they record. One is
Yes.
oral temperature, second thing is an axillary temperatures.
Yes.
Usually oral temperature is slightly reliable, axillary temperature slightly less reliable. Ideal thing is rectal, but rectal is most difficult for practical purposes. The two things. Children, they do record yesterday, they will discuss the thing there. So the problem is whatever site, for example, they want to record the oral temperature, fine for me. They record the axillary temperature, that's fine for me. But when a patient is stable to me and there is no other symptoms except fever. For example, last week one lady, 45-year-old female, she keep on telling 3 months fever. I asked what is the temperature recorded. She said always by touch or the feeling. I asked to record the temperature. All the temperatures normal. What she got it? She got a perimenopausal. The patient has got the hot flushes. So she recorded hot flushes as a temperatures, and she was extensively investigated in the last 3 months. All investigations, including PET-CT. But for nobody is recorded the temperatures. So keep on saying that patients is telling fever, fever, fever. Everybody is investigating, but the patient was stable to me. I asked to record the temperature. The recording temperature was missing. So the first and foremost thing is when you think the suspicion, the patient is not sick to you, and the patient is stable and no other symptoms is fitting into picture, please ask them to record. Whatever site is fine. Thermometer, either mercury thermometer or electronic thermometer, I'm fine. Only thing, don't use a handheld thermometer. People also record handheld thermometer and say there's no temperatures. They're running 101, 102, but handheld temperatures never picks up the temperatures. Check whether it's a mercury or digital thermometer, that's fine. Either oral or axillary is fine. Record the temperature. That's the single most important physical examinations finding. People are missing it out there. And second thing, we need to do a detailed general examinations head to toe. There is no need for systemic also head to toe, particularly look for signs of rashes. That's most important thing in fever, particularly in the community acquired fever. Look for Ishka, like scrub typhus. When the fever is more than 7 to 10 days, based upon the background, suburban history and everything. The row spots, everything for typhoid fever, we are not seeing now. Splenomegaly, lymph node, that's more important. So look for any lymph glands enlargement is present or not. Splenomegaly is present or not. These things is very important to think about it. Similarly, jaundice, conjunctival congestions. So that's why I said head to toe is examination is very important. When you think the patient has got more than 15 days fever, definitely auscultate the heart. Look for any diastolic murmur to look infective endocarditis. Because most of the times systolic murmur won't give you a clue to me, but diastolic murmur always think about infective endocarditis. Look for any peripheral manifestations of infective endocarditis. Similarly, TB means always look for gland, not only the cervical, axillary, inguinal region examine. And genital region, most failed thing there is particularly for scrub typhus, genital region, as well as for a female patients in presence of attender, you need to examine the armpit or below the breast, because most of the time the bite is painless. The patient won't complain. Unless we examine the patients, we won't pick up the HCAR. So we need to examine head to toe.
Yeah, I think Suresh, you have given good points. Of course, in short time, you cannot cover every point, but you gave a very important point. Whenever you examine the lady, especially private parts, you should have an attendant. Otherwise, it lead to medico-legal problems. So that is also important point. The error what they make is they examine a lady without a female attendant. It may lead to problem. That's a good point. Now I come to Ravindra, and you were saying about auscultation. Not only murmur, you have to auscultate for breath sounds also. Any Ralls, Rankai, any things like that also is useful for diagnosis. Coming to Ravindra, any localized infection. What are the examinations we have to do to confirm the diagnosis?
Localized. Look for dengue rash. Look for scrub typhus rash or rickettsial fever. Look for tonsillar infection. Look for throat patch. There is a white patch on the throat. Look for rhonchi. Look for, like he said, murmurs, splenomegaly, hepatomegaly.
Any localized abscess, localized boil?
Localized abscess, and more importantly, cellulitis.
Yeah. So general examination is important. Localized examination is also important.
Also
That's why
important.
I just want to. I come to Anupam again. The physical sign is very important. The critical to assess vital signs in febrile illness. What common mistakes physicians make?
Well, yes, sir, it is very important. Vital signs are to be taken in every patient, and we should concentrate upon taking them and not just go to systemic examination. It is important, as Dr. Suresh also said, temperature recording is very important, and that actually serves as a yardstick also. At the first visit, if the patient is not responding And not only temperature charting in the clinic, but at home also we should ask the patient. And that is where the importance of history taking is also there. To identify patterns of fever, it is very, very important. That actually at times gives us the clue. Also in cases where we have biphasic illnesses, then also you can pick up when you have the fever chart with you. So temperature recording is very important. And in the clinic also, the first thing when the patient comes to us and says fever, we ask the patient to go to the nursing staff and get the temperature recorded. Because there are many persons who feel feverish but are actually not feverish. As Dr. Suresh just gave an example of hot flushes in ladies. So which is just a example. So temperature important. Again, pulse is also very important. At times we don't cater to it. So it is important to see whether the pulse is actually proportionate to the temperature rise. So we all understand 1 degree centigrade, 10 beats per minute rise. So that also has to be taken care of, because that also gives us a potential diagnostic clue. If the patient has relative bradycardia, that means the temperature is high, but the pulse has not increased to the same extent as it is expected. Then also we have a clue to the diagnosis. Relative bradycardia, we all understand one of the commonest diseases is enteric fever. And I see there are a whole lot of questions related to enteric fever in the chat box. So vitals are very important. Similarly, BP is also very important. Patient may come walking, but as Dr. Suresh was saying, at times the patient may be having a community-acquired infection which is severe. And the patient is having, especially in dengue, as Dr. Ravindra was also saying, narrow pulse pressure is very important. It is a sign of impending shock. So the patient may be in compensated shock at that time. And if the patient has narrow pulse pressure, if the history is short and maybe a rash is there, you should always suspect for dengue fever also. Similarly, the patient may be going into hypotension. So yes, sir, vitals are very important, rightly said, and we should pay attention to all the vitals.
Yeah, because in a fever, vitals very, very important. That is the point we want to make, especially in a gram septicemia, negative septicemia, shock and all that, and then hurried breathing and things like that. We should not miss. Even in a fever, it's not normal fever. It has got complicated things. So that's why vital signs to be looked for in fever cases also. I'll come to Vinita. You were talking about the diagnostic challenges. What diagnostic challenges limit the development of newer modern modalities? There are a lot of newer modalities have come. So what diagnostic challenges are there to limit the...
Sir, first of all, I think if I talk about from microbiology point of view, then to understand the infectious pathology is very important to develop any diagnostic kit. So one is your lack of gold standard that we have for many infections. Whenever we want to develop a new test, obviously we want to compare it with a gold standard or a comparator which is perfect. Now we do not have any test which is 100% perfect. So that lack of a gold standard for many infections is a big limitation for us. A lack of animal model for many infections also is a big problem, because animal model recapitulates the whole infectious cycle in a way that we understand all the stages of the infection and we can target the antigens and then develop the kits. Plus, sir, the convention, the brief, as I said, as I mentioned before also, the transient presence of the bacteria or the intracellular nature of the bacteria. These are some of the problems because of which we are not able to understand the pathology properly or harness the antigens or various targets properly. And that is why there is a delay in, that is why we do not have a test which is, which can give us in black and white as to whether the infection is present or not. So these are some of the limitations.
Thank you. Thank you, Vinita. I request the panelists, please look into the chat box, and whenever you are not answering, please answer in the chat box. Anupam, there are a lot of questions you said. We may not have time to ask all questions. Please, then and there, you answer the questions. So as Suresh did it. Ravindra, you also see the questions and you answer. Vinita, so that it will save time when we go for the next. Again, one more history, Suresh, I'm really interested. The PUO case. What is the average time the GPs take, and how does it affect in the diagnosis of PO, the history? Because we were always talking about history. Suresh, we had a one full lecture on history taking fever last time. So yes, Suresh, tell me that.
Yeah, yes, sir. For example, the PO, the previous definitions of lasting for 3 weeks is almost gone. Most of the time now the new definition is, even the patient want to do 3 days, every test is over. As I told my earlier case, even PET-CT, everything is over within 2 weeks time there. So nowadays, there's no need for waiting for 3 weeks to find out on 3 temperatures. So when the temperature is significant, as slightly pointed my panelists there, when the temperature is more than 100.4 degrees and the patient has got more than 3 occasions, and if you did a reasonable examinations and reasonable history taking, still the fever is persisting, we need to do little bit focus to the patients. So what we usually do, first 3 days, we assess the first thing, stability of the patients. And the stability is there. For example, some of the participants puts about Q-SOFA score is very high, what to do? The Q-SOFA score is a simple thing, vital parameters only. What is this, a systolic BP? What is your respiratory rate? And what is your heart rate there? So this is what we are looking at it. And what is this conscious level? That's what we are looking at it. So when you use a simple vital parameters, when the patient is stable to me, I can wait for 3 days because most of the viral fever can subside within 3 days by just giving paracetamol if the patient is uncomfortable, rightly pointed by Dr. Anupam Prakash sir. So he clearly told when the patient is uncomfortable, give paracetamol, make the persons comfortable, ask him to record the temperatures, wait for 3 days. When the fever crosses more than 3 days or the patient is approaching 5th day of the fever, we need to take proper history and do one more time of examinations, whether I missed something or not. Look for certain clues and do some basic investigations. And the fever crosses more than 7 days, still the patient has got fever and recorded temperature shows more than 100.4 on multiple occasions, 3 or 4 times the fever is happening. Then again reinvestigate whether I missed something or not, elicit the history proper, whether you missed out or something, do the detailed physical examinations, including vital and systemic examinations. Then you need to do some cultures, what other panelists is suggesting about panels. For example, one interesting point is she's talking about the multiplex panel. One panel is called gastrointestinal panel, GI panel. It has got 15 organisms. When the patient has got diarrhea, particularly if you want to find out, people still using the old outdated test called Vibrio, the Dartling motility. They want to see the thing there, but right now we are not seeing it there. If you do the Vibrio, like GI panel, gastrointestinal panel, we can able to figure out what is going on. The beautiful thing is telling the panel itself, the diarrhea will stop. For example, I tell the patients, you got diarrhea, one beautiful test is there. This has got 15 organisms, I can find out, but the cost of the test is 15,000. The diarrhea stops immediately. So this is a test we can use indirectly to stop diarrhea also. So we need to see 3 days fever, I can wait for some time. 3 to 5 days fever, basic investigations. More than 7 days, we need to do investigations, including the cultures, particularly blood cultures, and the fever is persisting. This is the approach we follow.
Thank you, Suresh. Ravindra, he was talking about blood culture. So kindly tell me what are the reference when you do blood culture, what are things you do? And yes, one more thing, Suresh, you said when you give the cost of the test, the fever subsides. One more, diarrhea subsides. Same way, if you admit a patient in a government hospital where there are 200 patients and the toilet is so bad, you ask him to get admitted, go to the toilet, diarrhea stops. It's one other way diarrhea
simplest
stops. Okay.
Way, sir.
Yeah. Ravi, I'm sorry, Ravindra, please go ahead.
Yes, sir. The most common error we do in ordering blood cultures is to take suboptimal blood volume. The important thing is to note that you have to take a minimum of 10 ml per bottle, preferably in 2 bottles, one for aerobic and one for anaerobic. Since we don't do much anaerobic, we take one aerobic, that is minimum of 10 ml. The problem is you tell the staff and they take the CBC, they take the blood for creatinine, electrolytes and all that. They use that and the last 2 ml they will put in the blood culture bottle, which is inadequate and may adversely affect the diagnosis. Secondly, it is very common in India, especially, that we order only one blood sample for culture. However, if that is, it has between 20 to 40% sensitivity, positivity. If we give 2 blood cultures, it nearly doubles. And 3 and more blood cultures have a much higher positivity rate. So, preferably 2 samples should be sent, especially in important conditions like septicemia, typhoid, and endocarditis. 15 minutes apart, preferably in 2 different sites. 3 samples at least for endocarditis. Second, important thing is ordering blood culture when patient is taking antibiotics. If you have to order a blood culture after a patient has taken 2 or 3 days of antibiotics, the best time to take the culture is just before the next dose. Because many people order blood culture as an afterthought. If antibiotics have been given for a long time, then truly the testing is practically useless. Another
Should
thing
you,
is,
Ravindra, should you mention in the blood culture for enteric and non-enteric group of organism, or
it
you
is
have to
better to
specify?
mention, but most cultures are done for both, sir. Aerobic. Anaerobic is very, very rarely done. And in most laboratories, it is not possible to do also. The cultures are not reported as for anaerobic. There's an important difference for this, because when you take anaerobic cultures, the culture bottle has to contain carbon dioxide, not oxygen, as in routine aerobic cultures. Now, also using iodine swab for this of cleaning the site. You should use preferably an alcoholic swab, scrub for minimum 30 seconds and let it dry for 30 seconds before you draw the sample. Another very important thing about blood culture is reporting non-pathogenic bacteria in the blood culture. The best example is Staph epidermidis as a blood culture positivity and treat according to that. That is usually not acceptable. Thank you, sir. Hello?
I think Dr. Muruganathan's
Dr. Muruganathan's video has hanged probably. I think Dr. Suresh Kumar, you can just answer the questions that are there on enteric. I think enteric, there are a lot many questions, and Dr. Suresh would do justice. There are Dr. Benita, you can also answer that IgM typhoid, typhoid testing and the testing of Vidal, the relevance.
Sir, I briefly mentioned in the beginning, I would again re-emphasize on the point that a single IgM reading or IgG reading is always a problem for us to interpret. A single IgM reading, we need a previous history of infection or vaccination history. A single IgG reading can be because of reinfection in convalescence or vaccination or carriage. So plus persistence of IgG, or in the early phase of the infection, the IgM titer might not be good enough. So that can lead to a false negativity thing. So the best in any serological test is a demonstration of fourfold rise, that is acute and convalescent sera, and then if you could demonstrate seroconversion.
So Vidal coming positive year after year is not important unless there is a rising titer. Usually it is because of diminishing titers. That is what you want to say, Dr. Benita?
Yes, sir. Yes.
Dr. Suresh, we would come to you because there is a question in the panel about the treatment of enteric and complicated enteric. You already answered that partial treated. And what is the role of quinolones today when we treat enteric?
Nowadays, the resistance mechanisms for the typhoid is called the NAST. That is naldixic acid resistant typhoid. Previously, till 2000, the common resistant mechanism is MDR typhoid. That means resistant to ampicillin, cotrimoxazole.
Dr. Muruganathan is back. We will go back to him.
Fluoroquinolone is working, but now
let us continue.
Yes, sir. So what is not working nowadays is naldixic acid. That means the naldixic acid is a first generation fluoroquinolone. And the first generation fluoroquinolone is not working. The second generation, third generation like Cipro, Oflox will not work. Only one fluoroquinolone called gatifloxacin might work because it needs two-step mutations. But unfortunately, gatifloxacin is banned in this part of the world because of the dysglycemia associated with gatifloxacin. So what we are using nowadays for typhoid is third generation cephalosporin. Hospitalized patients, ceftriaxone, or outpatients, even cefixime is fine, but dose is good dose we need to use. And second thing, we can use azithromycin, cotrimoxazole. That means all the drugs like amoxicillin, clavulanic acid, everything will work for typhoid except fluoroquinolone. If you use fluoroquinolone, initial response can happen, but relapses are more common. And similarly,
this is very important for everybody to understand. Fluoroquinolones will have partial response only. Patients will respond for a couple of days, and then you are going to head for trouble, which will actually be a problematic phase. Dr. Suresh, yes.
Yeah, okay.
You start, sir.
Yeah, I think before going to antibiotic, Anupam.
Yes, sir.
People give paracetamol 6th hourly, 8th hourly. The patients religiously take those medicines. Is it advisable to do that?
So, very brief answer, as Dr. Muruganathan already said. See, PRN prescriptions or regular dosing of antipyretics is not to be given, number one. It actually hampers the pattern of fever, which I already said. But yes, if the patient is incapacitated or if the patient is having an illness such as I said, maybe coronary artery disease or anemia, wherein the patient, you don't want that patient should have undue metabolic demands. Then in those rare cases, it may be actually beneficial, but it is as a blanket rule, it is to be avoided. Because that if you give 6 hourly, the patient is having temperature 12 hourly after 2 days, and your 6 hourly prescription is still continuing, it actually hinders with the equilibrium also, and it actually is adds to the drug toxicity also. So brief answer, not blanket for anybody and everybody.
Okay, thank you. Binita, everybody is talking about Vidal. In a periphery where typhoid is endemic and we don't have much facility, what are the simple lab tests? Because we'll always write Vidal and Vidal will be coming as positive and people start giving anti-typhoid drugs. So any clue for those people other than Vidal, anything else which can be done in a periphery, in an endemic area?
So I guess you're talking about point of care tests, sir.
Yes.
Yeah, so most of, as I said before also, sir, these point of care tests are basically sample in, answer out kind of a pattern. You insert the sample inside and or you put a drop of the sample, and then these are the formats where you just get the result within minutes or hours. So and all these high-end technologies are being incorporated in this format only. So point of care tests, again, these are very developed. They include multiplexing. They are very they are reasonably sensitive, specific, portable devices. And we can because we need to understand that the clinician actually is torn between two decisions. One, to start with a broad spectrum to prevent any complications, and on the other side, to narrow the spectrum to prevent any rise in resistance in future. We are well aware of MDR and XDR salmonella. So that is why here comes the role of point of care tests, and there's no dearth of point of care tests that are available in the market, sir, with the names of Typhi dot and so many other tests. So there are many, but probably in the later part of the section, we'll talk about what are the limitations of these tests.
But anyway, before that, people use, especially Suresh will also answer supplementary, Vidal once, then again rise in titer Vidal, and then eosinophilia in the blood, peripheral blood, TCDC, will they help to diagnose typhoid, Binita? People do Vidal once, and then again rise in titer after some time, and then blood also shows eosinophilia. Eosinophil count is less.
Rise in titer. So if we have two samples, we manage two samples from the patient, one from the acute phase and another from the convalescent phase, and we demonstrate rise in titer, then it is good enough, sir.
Okay. Suresh, would you like to add anything else in the typhoid?
Usually Vidal we don't do it, sir, because as an infectious disease specialist in Apollo, we got 5 people are there. Last 12 years, in fact, if we see our hospital data, hardly few Vidals. Per year, we see a lot of fever cases, but hardly few Vidal. That too, people, other specialty asking it. We don't ask for the Vidal test because Vidal has got limitations. First thing, this is a serological test. We need to wait for minimum 5 to 7 days. Then we need to show the rising data that has got more value. For example, there are so many salmonellas are there, but all can cause false positive Vidal because they are all commensals, particularly environmental commensals. We do not know whether the Vidal is positive because of the true salmonella or because of the commensals. I'm not sure. Similarly, once a patient has got infected truly with salmonella typhi, how long it's going to remain positive, we do not know, have any data. Similarly, what is the significant titer in tropical country? There is no studies. 1 in 80, 1 in 160, 1 in 320, there is no studies. Even other enterobacteriaceae like E. coli in the blood, that can cause false positive Vidal because Salmonella belongs to Enterobacteriaceae family. Even dengue can cause anesthetic responses also. And if you do little early, it is negative. So Vidal is a test of historical interest.
So Suresh, tell me, what is the confirmatory test to say the patient has got definite typhoid?
Blood culture is a gold standard to make a diagnosis of typhoid, but unfortunately, blood culture availability is a bit challenging for the primary care physicians. If you got a good, decent lab, the marker called CBC, if you do, the neutrophil count is normal, WBC count is normal, eosinophil count is 0 or 1. I'm saying about the percentage, not the absolute numbers. And along with the ESR is normal. Provided the history, the patient is a young guy for less than 40 years, eating most of the time outside food, and fever is lasting more than 7 days. That put your diagnosis pre-test possibility is very high.
Anupam, what are the clinical signs of typhoid?
Well, clinical signs could vary from a lot many things, sir. And high fever is one. And it is important that with fever, if the duration of fever that increases, the patient's toxemia increases. So what is classically described as a step ladder fashion, although with use of PRN prescriptions and NSAIDs now these days, we don't find that typical pattern. But yes, temperatures would be very high. As Dr. Suresh says, after 7 days, if you are having a patient of typhoid, patient would be running a temperature of 100 to 104 degree Fahrenheit, and patient would be very toxic. That is one. Number two, typhoid, as I said, relative bradycardia is important. So pulse will not be as high as the temperature. That is number two clue. Number three is typhoid can have any presentation. One of the commonest that we find is bronchitis. So patients at times can have dry cough and wheezing also if you auscultate the chest. That is important. And clinically, you can have a soft splenomegaly, which is very easily missed. So not a very moderate or massive splenomegaly, just slight enlargement, slightly palpable spleen. So one has to specifically look for it. That is one. At times, patients will also have slightly tender enlarged liver and a slightly tender hepatomegaly, which will also be there. And enteric hepatitis also is common. So there are a whole lot of manifestations, sir. Thrombocytopenia, eosinopenia, that can also be a hallmark. In fact, that many patients actually thrombocytopenia, people mix with malaria as well as dengue, and they at times miss enteric. So where Dr. Ravindra said fever continuing for into the second week, that definitely rules out dengue. Think of enteric. So enteric, if we prolong further, sir, it can have complications involving any part of the body. Enteric encephalopathy, meningism, even seizures, high grade fever can result on in all these things, and toxemia is very, very important, sir.
I think now also clinical examination is very important. History taking is important, and of course lab investigation. If you have get a support.
Even rash is also can always be seen.
And what about dichrotic pulse? We used to say the pulse particular, in typhoid. Do you get them in typhoid? Have you seen any such dichrotic pulse?
Yes, that can be done, but most of the people are actually not palpating the pulse these days. They go for automated instruments. So pulse and BP is only as dependent upon the what they say. So that is the problem. In fact, arrhythmias can be missed very easily because of that.
Suresh, can we do a therapeutic trial of antibiotic to diagnose fever and how it affects the fever case? Because empirically we give some antibiotics, regularly.
Yes, sir. Usually the therapeutic trial we try to avoid as much as possible because this is a two-hit spot to me there. It sometimes creates, for example, people use chloroquine thinking malaria is more common, but malaria number has gone down. After dengue has taken over, particularly there is a fight between Aedes and Anopheles. Now the Aedes is more virulent or more common compared to the Anopheles, so malaria is going down. Of late, we are not seeing that much malaria. So the problem is chloroquine can cause a lot of improvement with antiviral. During COVID also, there's a first drug promoted for COVID, the chloroquine, hydroxychloroquine, that's what's promoted there. So it has got good antiviral, it has got good immune, it has got a effect is there. So don't think empirical therapy is not good for fever cases. But when I can use empirical therapy, when the fever is lasting more than 7 days, and the history suggests you of either typhoid or leptospirosis or scrub typhus. For example, these things is a bit difficult. For example, typhoid, you can send the cultures, but again, the heal can happen 3 days or 4 days later, the culture can grow. Already the patient has got 7 days of fever. If I can wait for the culture report, another 3-4 days, he can suffer. Similarly, leptospirosis and scrub typhus, the lab investigation is always challenging. The serology
I'm sorry to interrupt. In those situations when we are having confusion, people give doxycycline empirically.
So instead of doxycycline, what I say, doxycycline is a good drug for scrub typhus. It is a good drug for leptospirosis. Common community-acquired infections in a tropical country, 3 things I need to treat: typhoid, lepto, scrub. If at all, some URI, viral URI that became converted into bacterial URI or sometimes streptococcal. So what is the best empirical therapy? After 5 to 7 days, if you are not able to make diagnosis or waiting for diagnosis, macrolide like azithromycin, because it covers typhoid, it covers lepto, it covers scrub typhus. It won't, for example, the doxycycline is not a good drug for typhoid. Tetracycline is not that effective for typhoid. So we are missing the typhoid if you put doxycycline there.
Okay. Ravindra, now I'll ask you a different question. Kindly send me a few scenarios where antibiotics are prescribed when they are not really indicated.
Yes, sir. It's an excellent question. The first I would say is upper respiratory infection. 80% and more of upper respiratory infections is influenza or influenza-like syndrome or a viral syndrome. It is very, very rare to have unless there is a patch, a throat, posterior pharyngeal wall patch, or a tonsillar patch, it is most likely going to be a upper respiratory infection secondary to a viral infection. However, most of us, including myself, we sometimes, most of the time, prescribe azithromycin for this, though we may still think in terms of a viral infection. The second is small wounds and abrasions. It is better to clean with soap and water or a betadine wash. And if you really think that it is going to get infected, the better thing is to use just a mucosine ointment rather than prescribe antibiotics like aquamoxiclav. The third and the most important, especially in our country, is acute gastroenteritis. Most acute gastroenteritis are either viral or chemical, and most often they are self-limiting. Whether you give antibiotics or not, they usually subside within 48 to 72 hours. So, but as a rule, we prescribe acute gastroenteritis. For all acute gastroenteritis, we prescribe antibiotics, which is not really indicated. The fourth is presumed UTI. You assume that the patient has UTI and then start treatment without doing even a basic urine routine. If the urine routine is normal, there is truly no indication for starting an antibiotic. The next one is to treat for typhoid based on viral positivity of 1:80. Most doctors start antibiotics like cefixime when they see a viral positive. The viral positivity actually should be more than 1 in 160 or in 1 in 320, at least to think of typhoid. Though, like Suresh said, I do not agree that the viral is a good test for typhoid unless you show rising titers, which is very, very rarely done. And the last one is simple thing like dog bite. A dog bite, unless it is multiple and very deep, you just require to give Rabipur and not to give any antibiotics and tetanus injection and not to give any antibiotics for healing. Unless you put a suturing, unless you've done suturing or the flesh has been exposed. These are some important conditions, minor but very, very important conditions.
Ravindra, what did you say? Dog bite, suturing?
If you have sutured this one, which you should not actually.
You should not.
If you have sutured or if you have the large fleshy wounds, you may require to give antibiotics. Otherwise, a normal dog bite, you do not give antibiotics.
Yeah.
Not
also,
suture for that matter.
You should not suture dog bite.
Yeah, you should not suture. That's what I said.
And another thing, when you give antibiotic empirically like amoxicillin, that itself can cause diarrhea.
Exactly.
Loose motion. So many times, people take amoxicillin, they're saying that it is a broad spectrum antibiotic, which is good. But sometimes they land in loose motion. Yeah, because this I said, because today morning only my sister took like that and then talked to me about this. Coming to Anupam,
Yes, sir.
what is your opinion about antibiotics? Sometimes, non-infectious cases also there. And those cases, fever, do you think antibiotics will be useful?
Well, antibiotics, sir, they have to be used very judiciously. They should not be used rampantly. So fever occurring for a 1 day and patient is not having any other symptoms, I think we should wait and watch and time should be given. If the fever is persistent for a couple of days and the patient is troubled by that, then definitely we should go ahead and get the patients investigated. And depending upon the season, it all depends. So if we have something like some symptoms of the upper respiratory tract, antibiotics may not be beneficial unless until we find tonsillitis or we have a localizing sign or symptom. So that is very important. If the trend, seasonal trend, the trend in that particular geographical area, so those things actually guide our antibiotic choices. And we should desist from using antibiotics for illnesses like common cold, upper respiratory tract infections, and even when we suspect viral illnesses. So that is important. If you have an influenza-like illness or if we have dengue high on the cards, then definitely we should desist from using antibiotics. So there is something called antibiotic stewardship and antimicrobial resistance. We need to be taking care of it. We are already discussing about enteric, which is such a problem. So non-infectious causes not only could be non-bacterial causes. That is one part where antibiotics will fail. But yes, there could be a whole lot of other diseases like vasculitis, patients having thrombosis, like deep vein thrombosis or pulmonary thromboembolism, factitious fevers, drug fevers at times. So we will need to be very careful when we start patient on antibiotics. So history taking again and examination would be the helpful diagnostic tools.
Okay, Madam Vinita, you are in a tertiary care center, what are the common microbiological etiology you come across, whether it's blood culture, urine culture, or sputum culture, or pus culture? What are the common microbiological etiology you can come across?
There is a myriad of causes, sir. There are many gram-positive organisms, gram-negative organisms. We can actually classify on the basis of whether they are gastrointestinal or respiratory. These are the broad two categories, but otherwise the most common is malaria, of course, and then non-malarial illnesses like dengue and scrub typhus, leptospirosis, typhoid, so, and plus brucellosis, then certain rickettsial infections also, sir. So causes are many, sir, and that is why there's so much of confusion.
Okay. Suresh, suppose I am in a periphery. I don't order for any investigation and I treat empirically and I treat with my clinical vision. What are the consequences of not ordering the appropriate lab test in febrile patients?
Usually, if your resources are limited and your clinical acumen is good, then it's usually most of the time we need to treat based upon our clinical history and physical examinations. We can't rely on the lab investigations, particularly in the remote part, because I worked, even though I practices in corporate, but I exposed to the rural part also. I worked in a primary health center, sub-center, everything I exposed. So there I can't use like whatever investigations I'm using right now. So that point of time, yes, you are justified, provided you did the proper clinical examinations and history taking, yes, and your pre-test possibility, you can be able to narrow down or at least write down a couple of differential diagnoses, yes, you can use to treat. That's why I said the duration is very important. 3 to 5 days, yes, patient is stable, you can hold on. More than 5 days, you think about certain diagnosis that needs antibiotic, but your resources are limited. That point of you can use. Nowadays, WHO has given the antibiotic into 3 classes: aware group of antibiotic, watch group of antibiotics, and reserve group of antibiotics. That aware group of antibiotics you can use. Access, that means access group of antibiotic, we can put it. Access, you can use it. Watch group, we can't use it. And reserve group, definitely no. So access group of antibiotic like this macrolides.
Suresh,
yes, sir.
Very slowly, tell me once again, aware group of antibiotics.
WHO has divided the antibiotics into 3 classes, sir. Access,
slowly, yes.
Access group, watch group, and reserve group. Yes. Reserve group comes in a later category like colistin, polymyxin B, linezolid. This type of antibiotic come in a reserve group that is only used in ICU settings. Watch group of antibiotics like carbapenem, imipenem, meropenem, piperacillin, tazobactam, cefoperazone. Hospitalized patients. Access group for OP patients, you can use this molecule even if the testing is little, availability is big challenging to you, provided you got a diagnosis, either at least provisional diagnosis, right? 2 to 3 possibilities. You can use one among the access group of antibiotic. If you make pre-test possibility is bit high, you can use it.
Supplementary question. We order for lab investigation. What are the pitfalls in interpretation? Each one interpreted differently. So what are the pitfalls in investigations interpretation?
The most common interpretations we are discussing so far is a Vidal. People are interpreting 1 in 20 also positive, 1 in 40 also positive. It's a bit difficult. That is, 1 Vidal is a bit difficult. Similarly, tests also. For example, people interpreting urine cultures without urine routine before the urinary symptoms. Lot of people has got asymptomatic bacteria, particularly diabetic people. If you do urine cultures, definitely 1 lakh colony count will present. But if you ask the patient, is there any history of dysuria, any urgency, any fever, nothing. So people are treating this asymptomatic bacteria most of the time. There is other interpretations wrong. And third thing, if you do blood cultures, most of the time people send 1 ml, 2 ml blood. How they take the sample? Just wipe with some cotton swab. Not even 10 seconds. Just wipe the skin, immediately put the needle and draw the sample. All the skin contains most of the time coagulase positive staphylococci. That is not staph aureus. This is a skin commensal. And the report comes as coagulase negative staph, people treating antibiotic, because coagulase negative staph, they think that is very important thing. And similarly, when there is no rain, leptospirosis can happen if you need to walk through the rainwater or wade through the rainwater or at least swimming. But these things is not happen. Hot of summer, no water exposure, no agricultural job, not even standing in the field, paddy field, leptospiro IgM positive, or some MSAT test done in MGR University or Madhavaram Agricultural University, they did it, MSAT positive, this is a titer. Most of the time, it is a false positive. All serology take with a pinch of salt. That too, second day. They do second day, third day, lepto IgM is positive. Scrub IgM is positive on day 2. So always serological tests do not interpret before 3 to 5 days, minimum 5 days, ideally 7 days. So these.
Vinita, you tell me what are the pitfalls in interpretation. For example, you give us absolute eosinophil count. You give immature platelets. You give ESR. So many things, RWD, DUWD, so many things in ESR and TCDC. So tell me, what are the significance of this?
These are as a microbiologist, but as a microbiologist, the most important thing that I would like to point out here, one very important message I would use this platform to give is that, sir, without there's already an attitude of ordering a test, because we have the kits are flooding in the market. So this is a habit of ordering the test without assessing the pre-test probability for an infection. And with the increased sensitivity of all these techniques, this is exaggerated. The false positivity chances are exaggerated. So, ये IgM positive, especially in the initial stages of the infection, sir, कभी IgM negative या blood culture negative आ गया या IgG positive आ गया. So we really need to be careful as to the timing of the sample that we are, or kind of sample that we are collecting, timing of the sample, and the pre-test probability of the infection, how good it was. Because otherwise it makes no sense. As I said, we are treating the patient, not the report, and it is not 100% perfect. Nothing is perfect. So we have to keep that in mind.
Yeah. Okay, Anupam, as a clinician, what are the pitfalls in interpretation? Because every day you write the TCDC, ESR, blood picture, and so many things. So what are the informations you get it in this, and what are the pitfalls in the interpretation? ESR, for example.
As Dr. Benita and Dr. Suresh rightly said, so whenever one sends a test, one should understand the report has to be in proper order. If you send the test on day 1, don't expect that IgM will be positive so early. If you send the report in the first week, one should not expect that the Vidal is going to be positive in the first week. So the tests would have to be interpreted in that way. And yes, false positives, otherwise these would be all false positives. Similarly, if the blood culture, as already has been said, and Dr. Ravindra also said about the urine culture, the techniques are very important. So one has to understand when and how the test has to be done, and it has to be done in the right earnest. And we should understand that doing a panel and one test coming positive has to be seen in the clinical test relevance. So if the patient is having a clinically relevant, if you suspect that, then you should treat that. Don't think that once you have a panel, the panel comes positive, but the patient was not clinically suspected to be having that illness, then we should take it with a pinch of salt. That is what I would say. So clinical decision and discretion should always stand, supported by obviously testing.
Yeah, especially
it should not be the other way around.
Especially Anupam, sputum for AFB you write, and sometimes sputum for AFB comes as negative, but still you treat as a anti-TB drugs. What do you say, Ravindra, in your experience about tuberculosis?
Yes, very many a time saliva is given. So that is one of the reasons why sputum may be falsely negative. Number 2, there is an entity called smear negative pulmonary tuberculosis. It's first described in Hong Kong, but later is accepted all over the world. And the second thing is, it is better to look at the radiological features, the clinical entities, and then decide based on the history of fever, constitutional symptoms, cough with expectoration, and a chest X-ray with upper lung infiltrates. Such a case, you may clinically think that it is tuberculosis. If you cannot do the sputum 3 samples minimum come negative, and a gene expert comes negative, it might be smear negative pulmonary tuberculosis. Considering the clinical situation, I think we should treat. At least for the first 3 weeks, in which case you will know whether you are right or wrong.
Yeah, I think that's a very good point. Anupam, you say about paracetamol. long time people take NSAID and paracetamol as innocuous, especially paracetamol. You think innocuous paracetamol for long time?
Sir, paracetamol, as well as no drug is harmless. But yes, if we talk of antipyretics and NSAIDs, then paracetamol definitely is much less toxic. But there is a caveat: we should be very careful when using these drugs, even paracetamol, because we do not know what is the underlying comorbid that the patient is having, especially hepatic illnesses or in elderly population. The toxic dose may be much less. And with, as in the opening sentence, you said 650 milligram paracetamol being used. So if the patient is using 650 milligram every 4 hourly, then that is probably the ceiling dose. So 4 to 6 grams for paracetamol per day is the ceiling dose. And any patient taking more than 4 grams a day, we have to be very careful, especially if the renal and the hepatic function is compromised. So we should be very cautious when we use these drugs.
In fact,
But yes,
Anupam,
the therapeutic efficacy, safety margin is quite a lot with paracetamol.
Anupam, recent European hypertension guidelines, they've said paracetamol also can produce hypertension. 1.4 times more than the normal. So, as a hypertension man, this is an important point. We learned only this 2024 guideline says paracetamol can produce hypertension long run. Okay, Suresh, now tell me, suppose the implications of not following up on pending test results in the management of febrile illness.
Most of the time, the blood cultures are ordered. People think they need to wait for 7 days. Most of the laboratories, particularly in the corporate as well as in private, they are using an automatic system. That means you can check the lab, call the lab, ask any growth happened or not. Because what we are using is an automatic system. The blood culture, when we put it in an incubator, when bacteria grows, it releases carbon dioxide. That is sensed by the sensor behind it. So immediately it gives a light. So they remove the bottles and do the subcultures immediately. So don't wait, think typhoid means I need to wait for 7 days to get the answer. You can call the lab next day itself and get the answer, any growth is present or not. This is one of the common mistakes. They are not following up the report. Similarly, people always
Suresh, one minute. Growth means what is the culture count?
No, sir, the bacteria is growing in the blood culture bottle.
They say it's growing. They say next day when I say it is growing, it shows growing.
Yes, sir. So what will happen? The bottle will have a flag on it. So they remove the bottle, they put the gram stain immediately. The gram stain take hardly 15 to 20 minutes and say whether it's gram positive or gram negative. Most of the time, gram negative is important. Gram positive may be contaminations, provided if you send only one sample. That's the problem. Second most important thing is what they're not following. They always ask for AAB smear alone. Sometimes the AAB smear is more non-specific also. It can pick non-TB mycobacteria. They didn't ask for AAB culture. And if they ask for AAB culture, they're not following because it will take 4 to 6 weeks, people think. But average time for TB bacteria to grow is 3 weeks time. So don't think 6 weeks is needed. Nowadays, the resistance is very high. INH resistance in India is 21%. So don't think rifampicin sensitive by expert MTB, but INH resistant will be there. So always ask AAB culture whenever you wanted for a TB diagnosis. Please do, because India has got 20% mono resistance to INH. Rifampicin resistance is bit less, but INH resistance is very high. And people, what they do at the end of 2 months, they cut 2 drugs, combutal and they cut to the ethambutol and pyrazinamide and keep rifampicin and INH alone. INH is resistant. So you're giving only one drug. So that is not good. So these are the 2 common mistakes. They think culture means they need to wait for 7 days and they don't follow the appropriate cultures. Whatever they sent previously, they fail to follow the culture reports. We need to call the lab and check what is growing. That we need to follow it up.
Anupam, I want to ask a little out of the way question. Do you think fungus infection is common problem for a fever, and when do you send fungal culture? When you suspect
Well,
fungus infection?
at the outset, yes, it is as and it actually requires a lot of clinical acumen also. But commonly in patients who come to you walking, it is highly unlikely that they will be harboring a fungal infection. Serious, I would say deep mycosis. Superficial fungal infections quite common. Yes, rarely we do encounter patients who have deep mycosis also at times, or systemic mycosis that we say they can be having, but in immunocompetent patients. So number one is the patient is immunocompromised you should always think of fungal infections, wherein antibiotics would not be, the patient would not be responding to antibiotics. That is number one. Number two, those patients who are on antibiotics for a fair degree of time, maybe a week or 10 days, then the chances of having a fungal infection in these patients is high. The third thing is patients who are hospitalized and are on indwelling catheters. Now, these are the third category of patients who will have, who are more likely to have infections. And in fact, if they have hypotension or are running fever, then one should definitely think of fungal infections. So these are just three common scenarios that I have said. But yes, a high degree of suspicion should be there in all PUO patients also. Especially then there are subgroups like patients who have received prednisone or immunocompromised status or chemotherapeutic drugs also. So all these are special groups, post-transplant recipients. These are different groups which can always have fungal infections. And in fact, in these, the latter three categories, the number one diagnosis at times may be fungal infections.
Suresh, you would like to add some more, because we were all thrilled and excited when somebody diagnosed mucormycosis in COVID patients. So fungal has come to the market from that day onwards. Everybody starts doing fungal diagnosis also. Your views and comments on that.
Sir has clearly summarized whatever things, the three broad headings Sir has summarized. Usually we need to think about whether it's community acquired or hospital acquired. And one more is whether the patient is a neutropenic or immunocompromised. That is more important. Immunocompromised means HIV is more common. If you think HIV, the commonest fungus in HIV is PCP. Previously, now it's called PJP, Pneumocystis jirovecii pneumoniae. So we need to think about what sort of host before we think about the fungus. Hospitalized, Sir rightly pointed out, indwelling lines, antibiotic exposure more than 7 days, still fever is persisting. I need to think about fungus means I always ask my registrar to write, don't write fungus, whether you think yeast or yeast-like fungus like candida or mold. Mold means aspergillus or mucormycosis or similar things we need to write. So yeast or yeast-like fungus, most likely it's candida, happening in ICU settings, where after Sir currently told 5 to 7 days of antibiotic, indwelling line, major antibiotic exposures, or major surgery, abdominal surgery also one of the risk factors. Community acquired, coming to the OPD settings, particularly yesterday we got a good case there. Actually, the patient is presented with 2 months history from Northeast. Patient has got similar presentation of tuberculosis. Lungs, some nodules were there, some mediastinal nodes is also present. But what is the clue to me? He got a CT abdomen showing that bilateral adrenal enlargement. The immediate thought process is not TB. They think of TB. They started TB medications. Fever is still persisting. He came from Northeast to our hospital. So he immediately thought this is histoplasmosis to me. The Northeast patients taken 4 weeks of TB medications, no response, adrenal involvement, similar to TB presentations. I asked to do FNAC. Today evening, just before coming to the sessions, my pathologist called. She's saying that histoplasma-like organism is seen in the pathological examinations. So this is what, so community acquired, mostly endemic fungus has slightly turned out. In India, one of the commonest endemic fungus is histoplasmosis. That's more common, particularly the Northeast populations we are seeing across. Similarly, HIV means PCP pneumonia is more common. If the patient has got meningitis, not improving with the TB medication, think of cryptococcus. Similarly, in ICU settings, Candida is more common. Sometime during the time of COVID, we have seen a lot of aspergillosis as well as mucormycosis. Why? A lot of steroid exposures, So immunocompetent hosts, a lot of immunocompromising medication like steroid or other medications like transplant settings. They use a lot of medications that causes a person vulnerable to mold. Most of the mold infections, either aspergillus or mucor is possible. So this is how we divide and rightly point out everything, sir.
Yeah, because I asked this question. Last week we had a case. Somebody had gave a complaint. The physician missed the diagnosis of fungus. They diagnosed as tuberculosis and was treating. And then after the CT abdomen and CT MRI imaging, they found out and they suspected fungus. So is there any negligence on the part of the physician? That was the question asked in our panel. So we were answering those questions. That's why I thought from you also I'll get that expert opinion. Coming to the point of care, Vinita, you were talking about point of care. What is the role of point of care tests in AMR, antimicrobial resistance?
So basically, antimicrobial resistance is a pandemic, and to tackle that pandemic, we need diagnostic stewardship. Now, diagnostic stewardship is just like antibiotic stewardship. We use the right drug, right patient, right time, and so on. Similarly, diagnostic stewardship is using the right diagnostic tests for the appropriate patient at right time, without risking the clinically critically ill patients. So point of care test obviously would be a great help, because there is a lot of multiplexing, a lot of targets that are there in the point of care test. They are rapid, they give a rapid solution to the problem. So if we if we can come to the diagnosis early, then obviously the initiation of AAT, that is appropriate antimicrobial therapy, can be done in time, and discontinuation or de-escalation of unnecessary use of antibiotics also can be done on time, thereby preventing antimicrobial resistance. So that's a mainstay. I would like to add here that antimicrobial stewardship doesn't act alone. You have to have a very strong diagnostic stewardship as well as a very robust infection control practices running in the hospital to have a successful overall stewardship programs.
Ravindra, when you suspect somebody has got HIV, what precautions you have to take when you ask for an investigation?
Sir, the first and the most important thing by law, legally, you should ask for the consent. If the patient refuses consent, you cannot do the test. That is the first legal point that one has to know. Okay. The second, the test, after the test is done, and if it comes positive, especially you should do an ELISA only. And if 2 ELISAs or a Western blot comes positive, it has to be explained to the patient regarding the positivity of the HIV and whether he requires further investigation and treatment, and whether his wife, his spouse should be informed about the the test positivity, and that the chance of infecting her or him may be there. The most important thing about HIV testing is to think about the legal aspect. Yes, because I have had patients who are simply point blank refused testing.
Yeah. Suresh, would you like to add anything more? Clinically, the patient refuses history of exposure, but clinically you feel the patient has got HIV. In a tricky situation, how do you tackle?
This is most difficult thing there. As Sarah has pointed out, the legal point is more important. We need to take the consent. Any point of time, they'll come back and tell. In fact, one of my oncologists, I remember, he got non-Hodgkin's lymphoma with 6 to 8 cycles of chemotherapy. The patient was not improving at all. She's a 60-year-old lady. So he was not at all improving. The oncologist thought something fishy. So he finally asked for HIV without her knowledge there. Then HIV came back positive. That point of time, the husband became very rude. We came for oncology treatment. Who has to do the HIV test? The oncologist immediately turned to us and asked what happened. I just asked for it and it's positive also. Unfortunately, the history, she underwent hysterectomy 5 years back or something there. That point of time, blood transfusion was given. That's not because of the sexual exposure. She got because of the blood transfusion in a small nursing home. We do not know. That's a possibility. That's what they're talking about there. So the person, husband, we came for oncology workup and we wanted the oncology care. Because she was not responding, standard chemotherapy was given. But unfortunately, she was not improving with the 6 to 8 cycles of chemotherapy. That made the clinician to think something is missing. So he asked for HIV, but without the consent. So that's why it landed sometimes. That's a problematic there. So usually what we do, some difficult cases, we are not suspecting the HIV are there. So what I'm telling is, we are doing a panel of tests. And HIV also comes under the panel. If you liked it, I can do the HIV. It's called option given to the patients, opting in or opting out. If you say, I don't want to do HIV test, I don't do the test there. If you want to do, I can do. But my pre-test possibility is a bit low, even though I know the person possible TB, HIV, I'm thinking there. This is called opting out or opting in method there. So we can tell the patients, if you want, I do the test. If you say no, that's an indirect consent. But again, in the court of law, it's not going to stand. But at least I inform the patients. I got the informed consent from him when the patient is willing to take. If the patient says no, we can't do it.
Yeah, see why I asked this question. Blood transfusion history is also important in fever diagnosis. And especially insurance people, they just like that give ECG, X-ray, then also HIV they include. Most of the insurance companies they include. And if you write without understanding the importance, the patients may get wild, how come you suspect HIV? Because some insurance companies, they insist HIV test also to be included in their panel.
Not
Isn't it?
only insurance companies, sir, even hospitals, okay, we can't take the employee. We can do hepatitis B, we can do hepatitis C testing, but HIV testing, again, the employee should give the consent whether you want to go pre-test, pre-employment check. Some of the hospitals mandatorily put HIV testing. That's also a little dubious one thing there.
Anupam, are you there? Anupam? Anupam Prakash?
There, sir.
You are there, okay.
I am there,
No.
sir. Yes, sir.
Yeah, and usually I ask HIV because many people who are having tuberculosis also have diabetes. Our diabetic patients develop tuberculosis. Now the tuberculosis control group also says look for HIV because people with HIV have more tuberculosis and tuberculosis patients have HIV. What is your experience in your hospital in HIV when you come across? How do you tackle and how do you write an investigation?
Well, these days, tuberculosis, under the program, it is mandatory that patients have to be tested for HIV as well as diabetes. And HIV and tuberculosis have a very difficult correlation. And in fact, tuberculosis is one of the indicator diseases for HIV. That is why actually it is mandatory now to test for tuberculosis in these patients and vice versa also. So that is one thing. So once it is mandatory, then the consent is important, as already has been said. And in fact, in every center now, whenever we advise HIV, a pre-test counseling and a post-test counseling are mandatory. So there is a pre-test counselor who does it and who explains all the nuances of the test also, and once if it is positive or if it is negative, so that scenario is explained very diligently. So that thing has gone out, but still, yes, there is a lot of stigma still despite the advances, awareness and whatnot about HIV. Similarly for blood sugar also, so it is important that tuberculosis patients, they have to be tested for blood sugar because in diabetics there is a high degree or high chance that the patient may be tuberculosis positive because it is an again immunocompromised state per se because hyperglycemia affects immunity. And similarly, so tuberculosis, any patient who has tuberculosis now, it is mandatory to get screened for a random blood sugar at least. So that is important so that we don't miss upon it because India is having a brunt of diabetics as well as tuberculosis. And with the aim of the government to eliminate tuberculosis by 2025, it is very, very important that we don't miss out because if the patient is undiagnosed diabetics and we start treatment, the treatment may also not be 100% effective because diabetes impairs immune function and patients' ATT also will not be as effective as it should be.
Yeah, why I asked this clinical question, Anupam? Anti-diabetic drugs can lead to tuberculosis. I mean, increase the problem. Anti-tuberculosis drugs also can lead to diabetes control problem. So you must understand the drugs of anti-diabetic and as well as anti-tuberculosis because vice versa can cause problems. That is the point I thought you can make it in the panel. Okay, now coming to you again. Sometimes, innocuous fever, people come 1 day fever, then 5 days they'll be happy. Again, after 7 days, they'll come. Like that, this will go on. You have come across so many cases like that. You are experiencing this and how do you manage those cases? Will you do investigation for all of them? And how do you give the treatment for these people?
Well, sir, as I already said, if the patient is comfortable and the patient does not have any very potential diagnostic clue and the fever subsides in 5 to 7 days, it may not require. But yes, it is equally important to see that these are not patient may have a fever for 1 day and then go back home. And this is what actually happened in COVID also. So we have to have a clinical suspicion, and that is what Dr. Suresh was also talking about. If you have that clinical acumen, it is very important because the patient may be having a biphasic illness or patient may land after about 3 to 5 days in an immunoinflammatory syndrome, as was witnessed with COVID. As we have in the rainy season, we have leptospirosis, scrub typhus, where at times you can have an initial phase which could be a short prodromal type of illness subsiding with a period of fever-free period of about 3 to 5 days or maybe 7 days, and then patient landing in complications. So this is important. But yes, if most of the times we will have some clinical clue, as Dr. Suresh was saying you should look for the SR, which is seen in about one third of the cases. Even leptospira, we have the population when we know when it should, when the season when it actually happens, and the areas also, arid areas, post rains, after rains. So these are the things which we should be very cautious about when we actually deal with such illnesses where the patients may not seem to be very sick at the initial point.
Yeah, Ravindra, now in those days we are talking about intermittent fever, remittent fever, continuous fever, Epstein fever, and particular type of fever for dengue and all that. Any, you can throw some light on those?
No, sir. I still think those old things of remittent fever and intermittent fever no more exist. In fact, it is very difficult to say, except probably in malaria. In malaria, it is the fever still comes once in 2 days or once in 3 days. Another thing, the standard stepladder pattern that we used to see in typhoid fever no more exists. Also because of management with antibiotics. We start antibiotics at a very, very early stage. So you may not see the typical stepladder pattern that you used to see in malaria. In typhoid fever. Another thing is evening rise of temperature in patients with tuberculosis. This is also not a common entity nowadays, though the patient might, if you ask a specific question, he might say, yes, sir, I have more fever in the evenings. But that is a normal thing. And so you cannot take those things. And I am not too very sure that Epstein fever and all will be diagnosed on a clinical basis. It is difficult, but possible sometimes. And of course, very rarely seen.
Yeah, Anupam, do you like to add some points on that?
I think, sir, it is well taken. We should have crisp answers, short answers only.
Okay, Suresh, because many times when we studied, we talked about by the type of fever we can get some flu. Do you still follow that, Suresh? Any added points?
Theoretical only, but typhoid, what we are seeing, not a classic step up and step down there, but usually typhoid takes the fever. What happened is the spacing out. For example, the patient is getting previously every third or fourth hour fever. Once you start putting an antibiotic, appropriate antibiotics, the fever space out initially. Instead of 4 to 6 hours, it comes 6 to 8 hours or 8 to 12 hours. Then gradually, similarly, it goes up also and goes down slowly only. On day 4, day 5, they start feeling well. Even though temperature chart, if you see, temperature is persisting, only it take day 5 to day 7 for fever to come down in typhoid. So we need to wait. But what will happen, whether the patient is improving or not, you can see the temperature chart and the spacing out can happen. Instead of every 4th hour or every 6th hour initially, it spaces out a little bit more. Otherwise, the sir said what will happen. The other things all are like, only for theory we can discuss for third-year medical students. Otherwise, it's got no practical evaluations for day-to-day practice, sir.
Okay, Binita.
The patterns have actually gone off, sir, with the indiscriminate use of antipyretics and NSAIDs now. So we hardly get true patterns these days.
Okay. Binita, what are the diagnostic challenges in diagnosing carriers? For example, typhoid carrier or any particular carrier. What are the diagnostic challenges?
So carriers would be a problem because they are asymptomatic, first of all. They themselves are not aware that they are carriers. Secondly, intermittent shedding hoti hai, sir. So obviously, it's not so easy to diagnose them. Uske alawa, sir, during the interpretation of the tests, the carriage concept has to be kept in mind. So I think that's the main problem, that intermittent shedding is the main problem. So false negativity ke chances are. So I think that is the main issue.
Okay, now Suresh, what are the general errors physicians make in serological tests and interpreting serological tests? One, and what errors surgeons make in writing the investigation? Because physicians, surgeons, different.
Yes, sir. Serological test we already discussed, sir. The timing is more important. When you ask for serological test, wait for 5 to 7 days because the body should recognize the pathogen and produces an antibody. That will take minimum 5 days. Ideally, 7 days is a gold standard. So don't interpret the serology or don't write the serological test initially. It's not serology. For example, dengue, IgM, and IgG is a serological test. NS1 is not a serological. This is an antigen-based test. If you want to write the NS1, do it on day 1, day 2. So we need to know the timelines of the testing. That is more important as far as physician is concerned. And second thing, always take with a pinch of salt, particularly IgM test. IgM has got a lot of false positivity. So always take with a pinch of salt unless your pre-test possibility correlate to the diagnosis. That's the second point. As far as surgeon is concerned, they start sending all the samples. For example, wound swab, they send the drain fluid, drain tip. These are all the things always contaminations. If your skin contains a lot of bacteria, if you do the throat do a throat swab, a lot of bacteria is present in the throat. These are all not sterile areas. These are all unsterile area. So microbiology lab should straight away reject certain samples. For example, the wound, they put a drain there. After surgery, they put a drain. After third day, fourth day, they send the drain fluid and send for cultures. When the fever happens, they take the drain fluid. If you send the drain fluid, some bacteria will grow, particularly polymicrobial growth can happen. They want to start eating antibiotics. Similarly, for a diabetic foot, ideal thing is we need to take a tissue from the theater what they debride. Suppose if they're not able to debride, they want to take a wound swab, what they need to do, first clean the wound with the normal saline, nothing, go and take the base, at least that can give some idea. But immediately to take from the superficial surface. These are all contaminations. So surgeon always send the drain fluid, drain tip. They remove the drain catheter and send the tip for the cultures. Most of the good microbiology labs, they are not accepting any tips. Only one tip they can accept is central line when we think patient has got central line bloodstream infections, but the culture is not growing. We are removing the central line just to want to check whether the central line is infected with the bacteria or not. That time we need to send the central line tip. Otherwise, the urinary catheter tip, endotracheal tip, the drain tip, wound swab, drain fluid, absolutely no role.
Vinita, do you agree what Suresh says about surgeons referring tests?
Absolutely. So these the sample, the tips, this is a clear instruction, sir. Because otherwise the diagnosis will be very difficult, the interpretation will be very difficult. So this has to be kept in.
Anupam, you are a great clinician. You would have come across so many patients, 15 days fever, all investigations normal, but still patient is unwell. How do you approach them?
Well, sir, as Dr. Suresh already said, sir, these are the patients who will land into the classical definition of fever of unknown origin. And we will need to then diligently work them up and re-examine these patients is very important. Take a good history again and chart their temperature, chart when they had fever, when they were fever free, and then again go to the examination. And they have to be examined from head to toe and sought for the potential diagnostic clue or the PDC, which is very important. And there are some clinical clues we should see for thrombosis, vasculitis. We should see for lymphadenopathy. Many of us do not actually see for lymph nodes in these patients. Also, we should see for hidden sites like the oral cavity, the nasopharynx, the sinuses. So all these things can lead a clue. In fact, a fundus examination at times can also suggest things. Similarly, abdominal examination, again, we should look for spleen and liver, which is very important. In fact, also lumps like lymph nodes in the liver, in the abdomen. And again, examining the inguinal area, the genitalia for lesions. And at times, we should also keep a note of the STIs, the sexually transmitted infections, which can keep continuing like this for weeks together. Similarly, HIV also would come in this category, fever on unexplained origin. Connective tissue disorders, non-infective illnesses. At times, drug fevers, we had a query or some queries, Dr. Suresh and myself have already answered. And at times, factitious fevers also, which are very, very important. But yes, non-infective causes like the cancers, leukemias, lymphomas, and vasculitis, connective tissue disorders, deep vein thrombosis, these things also need to be thought of. But yes, a diligent repeat of investigations. And if we don't get, then you will need to go through the whole body CT or a PET CT if you are very sure that the patient is having some illness like that. So that is the line of FEO, sir. So you will need to go for that management.
Yeah. In fact, one of my relatives underwent so many investigations, 2 months fever. He went to US also. They could not diagnose. When they came back to Apollo, Suresh diagnosed temporal arteritis. So, the cause of fever was temporal arteritis. So I think sometimes it is like that. But, surprisingly, I was in US last month. They say artificial intelligence if you feed all the investigations, history, and examination, it gives a diagnosis. It's quite funny because three pediatricians missed the diagnosis, but this artificial intelligence gave a diagnosis. And that's what
we give a diagnosis, but it is not necessary that it is always correct.
But anyway, that's the diagnosis they given. Suresh, now tell me few situations where the choice of antibiotics is incorrect and where the dose we fail in the physicians,
Yes, sir. Most of
We
the time,
already gave cefixime 1.
yes, sir. So most of the time, the dosing is underdosing. For example, in inpatient setting, they use cefotaxime 1 gram BD. That's one of the commonest mistakes people do. Who found out the dose of cefotaxime? Because I use during my CRRA, I used to give 1 gram BD dose because as a CRRA, it's a 2 doses is easy for me. And during my postgraduate, we written the prescriptions for my CRRA, 1 gram BD dose, cefotaxime. This is one of the commonly underdosed drug. Why we got a lot of cephalosporin resistance, particularly the ESBL organisms in India, because of the underdosing. Particularly the cefotaxime 1 gram BD dose for me, I can put it there. Because the dose of cefotaxime is 100 to 150 milligram per kilogram per day. Even if you consider the person is a 60 kilogram man, if you put 100 mg per kg, it comes around 6 grams per day. That means 2 gram TDS is a minimum dose. Similarly, most are saying ICU settings, OP settings, people write only thing ciprofloxacin. We as an infectious disease prefer 15 mg per kg per day. That means 750 milligram BD is a good dose for ciprofloxacin. And people are asking about azithromycin dose in the panel. Usually typhoid, if used as a monotherapy, 20 mg per kg. That means 1 gram per day is good dose. Suppose you use as a combination therapy, 10 mg per kg is fine. Cefixime means the dose is 400 milligram BD is a good dose. If you put 10 mg per kg per day, it comes around almost like a 400 milligram per BD is a good dose. In fact, all the companies, including micro labs, they removed 400 milligram out of the market because nobody is writing. If you write means 200 milligram, 2 tablets I need to write. Previously, they kept 400 milligram, but none of the company is now manufacturing 400 milligram. So I need to write 200 milligram, 2 tablets BD. And people say you're writing overdose, doctor. This is the correct dose. In fact, this is one of the reasons for underdosing because a pharmaceutical company, they are manufacturing a correct doses. That's the problem. If you write 2 doses means the doctor is writing overdose. So that's what we are doing it.
Suresh, actually, rifaximin, 400 milligram comes, 550 milligram comes, 200 milligram comes. As a tablet. So what is the ideal dose rifaximin?
Usually we don't prefer rifaximin except for the traveler's diarrhea. My gastroenterologist prefer for cirrhosis patients, but usually we prefer for traveler's diarrhea to prevent antibiotic. This is a form of antibiotic, but to preserve real antibiotic, it has got roles for us. Otherwise, we are not a fan of rifaximin in our practice there. But DCLD, it has got role, particularly for gut decolonization, it has got a role. Otherwise, apart from the traveler's diarrhea and gut decolonizations, rifaximin has got very limited role in a practice, sir.
But Suresh, gastroenterology will not agree with you because they give rifaximin day in and day out, especially for IBS and also for overgrowth of bacteria. They give cyclic rifaximin.
And decolonization.
Yes, so they give like that. So rifaximin dose 550 BD. Some people give 400 3 times a day. So what I am trying to impress, Dr. Manjula, if you are there, Jairaj, please come out with antibiotic dose chart. Because in the pediatrics, always, they have in the clinic, the pediatric dose. In the small book, only very less than 50 pages, Jairaj. You should help all the Fever Foundation, should give the correct dosage, get the Suresh and Ravindra and Anupam to correct it, get the dose correctly, and give a small handbook for all the clinicians from the Fever Foundation. One of the Fever Foundation activity should be that. So that will be a guide, like, it will be the table. So don't need to worry. Don't need to call Suresh, ask what is the dose. You just check and verify. All the antibiotic dose you can give. What do you say, Suresh, the idea?
Actually, I agree, sir. You only given an opportunity to write that. In one of the textbook of API medicines, we wrote about the dosing of the medicines. So I written one chapter under your guidance only that I remember vaguely. I can quote the chapter also. It's there in my website.
So Ravindra, you also give pressure to Manjula and then make sure
yes,
we
sir,
get a book.
Certainly.
We get a book.
Definitely,
like that.
Sir. This time we'll do it.
Yeah, because that is good for all the conditions.
We'll
Why break our heads to remember those things? It will be there in the table so that we can know what is the dose of cefixime, what is the dose of azithromycin, things like that. Okay. With the duration or with the reference to the mode of administration, what updates are physician lacking, Suresh?
So actually now the two concepts are emerging. That also I mentioned in the chat box there. So people are asking when the patient comes with 3 days fever, sick patients, I want to start IV antibiotic. One of the Scaptyphus paper recently published from CMC, they say initial couple of days of IV azithro plus IV doxy followed by subsequently oral is good. But as far as infectious disease is concerned, now two concepts is emerging. One, short is sweet. Second thing, the bacteria does not know how the antibiotic reaches it, whether it's oral or IV. Only thing what is required is the antibiotic should have good oral bioavailability and the source control should happen. The source should be controlled properly and the patient is stable enough or is able to swallow the drug. Then oral is equal to IV. Don't think IV is always superior. Nowadays on day 3, day 4, we are converting from IV to oral switch. That is called IV to oral switch to avoid a lot of infusion related complications. So when a patient is stable enough, we can use oral therapy. Even for endocarditis, people start using from day 7 to day 10. Previously, all 4 weeks I used to give IV. Similarly, for osteomyelitis, we used to give long-term IP therapy. Nowadays, most of the indications, oral is equal to IV, provided good oral drug, good oral bioavailability, good source control. We can use oral drug for most of the therapies. We can try, not necessarily IV is needed. Even in ICU settings, neutropenic, solid organ transplants, papers are emerging. Oral is good to IV.
Okay. Coming to the culture sensitivity, what are the consequences of not adjusting the sensitivity pattern and giving the drugs?
Most of the time, what happens, again working on a beautiful paper there. I'm taking the culture reports on the different labs. I came across the thing, whatever labs reports. Today I saw one report, Pseudomonas. They say Pseudomonas, the first generation cephalosporin is sensitive. Just now it's made in my mobile phone. I've taken a photograph of Pseudomonas. The first generation cephalosporin is sensitive. Pseudomonas is inherently resistant to first generation cephalosporin, like your cefazolin. Second generation cephalosporin, like cefuroxime. This will not work. Third generation cephalosporin selected. Ceftriaxone, cefotaxime will not work. Only ceftazidime, cefoperazone will work. So these things what will happen, they need to understand what is the basic interpretation. So you're suggesting about the dose. Similarly, with the help of microbiologists, we need to bring what are all the drugs we need to check in the culture report. For example, people are using according to the culture report, but the report was given by one technician. He has got no clue what to report also. That's what he reported. Fortunately, he's a PhD guy. He reported these things there. I just taken the photograph of the reports because I'm analyzing different reports there. So we need to know what to look for. For example, if you're looking for E. coli, commonly in the urinary infections, straight away look at the third generation cephalosporin. But if it is sensitive, use some simple generations or ciprofloxacin or cotrimoxazole. That's what we need to report. One of the good lab in Chennai, they report this much only 4 or 5 drugs. That's called the first line sensitivity. They will do the first line drug, for example, simple oral drug or simple IV drug. They report only 4 drugs. They won't give this much report. When the lab report is giving this much length, that is not a good lab to me. 25 drugs giving it means that's not a good lab.
So, Suresh, the lab report comes as resistant. They've given moderately sensitive for 2 drugs. Will you give 2 drugs or only 1 drug?
So this moderately sensitive is not a good lab. Actually, they need to say sensitive, resistance. If at all, they can comment on indeterminate or it's called water lab. And the resistance, the MIC falls in between the category. The moderately sensitive, around giving the values of 20 millimeter, 25 millimeter. These are all the humbug reports for me. Not a good lab to rely on it. So we need to know sensitive or resistant only. So don't go with moderately sensitive. The pre-test possibility, we need to decide where is the infections, whether to treat infections or not. If it is needed, the combination...
Your voice is not there, Suresh.
Sorry, sir. The combination therapy has got very limited role as far as antibiotics is concerned.
Suresh, your voice is not there.
What happens is...
No, sir, it's coming, sir. Actually, it's coming.
It's coming, sir.
Yes,
I am not muted, sir.
Yeah, okay. So please go ahead.
So combination therapy, as far as antibiotics is concerned, very limited role. There's no role for combination therapy, except in sick patients, shock patients. When come to the emergency, I had taken a cultures. I do not know that point of time. I use combination therapy. When I know the organisms, even for Pseudomonas, people think previously Pseudomonas needs 2 drugs, but now the concept is gone. 1 drug is enough. Moderately sensitive, what I do, all are resistance, only 1 or 2 drugs is called intermediate. That point of time, what we need to do, what is the best drug? For example, colistin, nowadays they're not reporting sensitive or resistant. They put the MIC value and says, this is intermediate only, they put it there. That point of time, yes, if you have no other options and the patient is really sick, shocky, that point of time we use a combination therapy. For a community fevers, there's no need for combination therapy.
Because Suresh, now the trend is for combination. Be it a diabetes, be it a hypertension, be it cancer, everything is combination. Only antibiotics, there is no combination, according to you. Maybe you may change it afterwards. Coming to Vinita, what is antimicrobial stewardship?
So I was just listening to Sir Dr. Suresh that cascade reporting and restricted reporting is very important these days. Rather than reporting elaborately about all the antibiotics, we first, if it is narrow spectrum, and then come to the broad spectrum. So yeah, that is a very important parameter. Antibiotic stewardship is in general the correct use of antibiotics at correct time and correct dose for correct patient. So to prevent resistance. That is what is antimicrobial stewardship is about. So that will include many things. It has prescription auditing, it has restrictive reporting, cascade, de-escalation. So it's a huge concept, but basically it is that we know that misuse, it's a prudent use of antibiotics. That is, we know that it is not overused or it is not unnecessary use of antibiotics is prevented.
Thank you, Vinita.
When the RRR movie has come there, we put 3 R's and one more R is called the antibiotic stewardship. Right patients, right drug, right dose, right duration.
Yes.
So we put like a RRR movie and put one more R, sir. That's it.
Okay. Anyway, Suresh, I think we'll use this for our antibiotic book. I am coming out with the antibiotic book, Vinita,
Yes.
comprehensive guide for antibiotics. I will approach you. You may also contribute an article.
Thank you.
Yeah. Thanks for the opportunity, Anupam. I'll get her help. So, Anupam, maybe we will have one round of questions for each one of you, and then we'll wind up. Anupam, Delhi records 47-degree temperature, and in a global warming is there. What is the error they make in fever management in these situations?
Well, it is very important, sir. During the summer months, especially not only in Delhi, but places in the coastal south also, where the temperatures are high and equally humid also, where heat loss may be prevented at times. It is very important that we take care of heat-related illnesses also. Many people will come with cramps. Many patients will come with gastrointestinal disturbance, loose motions. Patients will come with high temperature also, fever, heat hyperpyrexia, at times heat exhaustion, and unfortunately also heat stroke, especially the elderly population, which is very, very important, and this has to be taken care of. So temperature will also be high and the patients will have all these kinds of symptoms. So this is again one of the non-infective cause, and we should be very categorical when we are actually dealing with these patients, and we actually need to suspect them. So awareness is very important, and I think to mitigate this, you already asked in the initial part, it is important to avoid sunshine or have some shade, use umbrellas or have a lot of fluids also, and wear light and loose clothing, and don't use antibiotics in such patients, and use paracetamol very carefully in these patients, because these are the patients who will benefit by cooling and not necessarily by any medication. So physical measures, avoiding going out in heat, avoiding doing strenuous work, and having some electrolyte solutions or Nibu Pani, something like that, will definitely benefit them more and prevent heat related illnesses, which is, I think, which is going to be there throughout now in the times to come.
See, sometimes paradoxical situation. You advise them cooling. They go to air conditioned room. They feel chill and they take the blanket and do. So, what is the advice you give? Should they use air conditioning or should they use blanket?
Sir, air conditioning should not be used to 18 degrees. It should be the room temperature should be 25 to 28. That is ideal for all of us in any situation, be it winters or summers. So it is important. It should not be that we go to chill and then we use blankets to warm ourselves. Especially if the patient is having fever, blankets should not be used because it will prevent heat dissipation, which is very important, and Fever Foundation, and you have always been advocating that.
There's a common problem. They always have
Yes.
fever with chills and rigor. They use blankets.
So at that time, heat generation is heat dissipation is very important. So that is the problem. So we need to actually vent out the air, let the heat go out. So air cooling will benefit at that time. And during that phase of chills, the antipyretics may be required. But otherwise, physical cooling measures are very important whenever we have patients who are having fever. That is important, especially with heat-related illnesses.
Because in the pediatrician, they will say tepid sponging with warm water, cool water, things like that. For adults, does it apply?
Yes, tepid sponging is important, sir. If the temperature is 101, 102, 103, then tepid sponging. So tepid sponging means that room temperature water should be used. So 25, again 22 to 25 degrees centigrade. But if the fever is very high, then at times especially in heat hyperpyrexia or hyperthermia, at times you may need to have cold sponging also. So that depends upon what is the degree of elevation of fever. So that tepid sponging does work. So moderate grade fevers, yes, tepid sponging should be advised.
Okay. Vinita, your last question. You come across a lot of false positivity and false negativity.
Yes, sir.
How do you avoid it, and what is your advice in those situations?
False negative, sir, these are very common. False negativity would be especially the initial stages of the infection, especially in serology and all also, when the titer the antibodies take some time to appear. So obviously false negativity. Cultures, sir, they are suboptimal sensitivity. In the beginning, we have suboptimal sensitivity. There also you can get false negativity. False positivity is mostly due to contamination or cross reaction, especially salmonella and all. It has a very peculiar characteristic of cross reaction with other members of Enterobacteriaceae. So both of them are a problematic situation. If it is a false negative situation, then obviously the infection is there, but under treatment and false positivity, over treatment of the cases will occur. So antibiotic misuse will be the ultimate result, leading to again further adding to the menace of antimicrobial resistance. So this is very common with the serological tests as well as some of the gold standard culture methods that we use.
Thank you. We have covered history, physical science, management, investigation. Now, the last part of my questions will be patient education and prevention errors. Suresh, what are the common errors physicians make regarding dietary recommendations for a febrile patient?
Usually the people come and ask me what food to eat, what not to eat. Particularly they want to know what to eat there. So we usually say when a patient has got fever, but he's got a good appetite and is not having any vomiting sensations or any uneasy feeling or bloating sensations in the abdomen, I used to suggest take normal diet. So you take the normal diet, but most of the time people advise take kanji or some like a little bland diet there. So most of the time home prepared diet, they don't put too much of oil, too much of spice in the home. They're taking the same food. So take the normal diet so that you can have calorie to fight your infections. During fever, we need more calories because the temperature increases our requirements also. Unfortunately, people do take this one, take this one. The appetite, already the nausea will be there, appetite will be poor. And if you give some bland diet, whatever appetite they will really lose. I fondly say for adult patients, if you want, take biryani. Biryani also is fine for me, take it. I need some energy to fight infections. Similarly, for children, people say the child is not taking anything. I do pediatrics also. Ask them to take ice cream also because that's a more energetic one there. I need energy to fight the infection. So that's one of the most common error we encounter. Home food is fine, provided there's no nausea, no vomiting, they're eating normally. They don't have any uneasy feeling. Suppose if they got nausea, vomiting, not even tolerating anything, that's fine. Then we can go for bland. The patient has got normal appetite. Most of the time with fever, the patient has got normal appetite. So eat normal home food, anything is fine. Depending upon diabetes or depending upon hypertension, that's fine. Whatever requirement, that's fine. But for fever per se, there is no restrictions. Take normal, whatever diet they're taking before fever, continue to take.
You are given a very, what do you call, a controversial advice. Even if they want ice cream, you can take ice cream.
Because energy is more important, sir. Because the child is not taking anything, the child becomes this way and coming with a poor state, they want to give IV fluids. Instead of giving IV fluids, this is much important there. After ice cream, some infections come, that will take care of that. Don't worry.
I agree with Dr. Suresh. Fever is a hypercatabolic state and we need to be taking care of the calorie intake of these patients, calorie as well as fluid intake, sir.
Yeah, I wanted to ask you, Anupam, your comments, but you are given. Ravindra, What about personal hygiene in the management and recovery of patients?
Many patients do not take bath when they have fever. It is mandatory that they take the bath. Keep personal hygiene to a high level.
Warm water bath or cold water bath?
Lukewarm water bath at least. They may not be willing to take a cold water bath, but they can take a normal bath.
Head bath or body bath?
They can take a head bath even during fever. Many patients with dengue avoid taking bath at all till you discharge them. But that theory is useless. It is better to take a bath every day. Personal hygiene and oral hygiene should be maintained.
Okay, good, Ravindra. Suresh, how to prevent reinfection, transmission, etc.? What advice you give to the patient? Now we are talking about patient education.
Yes. So we know after treating the thing, most of the time we ignore his vaccination advice. A lot of things, particularly the community acquired events, we can prevent. For example, the person is getting typhoid. He used to continue to eat same habit. Even though we say avoid for 1 month or 2 months, he can avoid eating outside food. Again, at the end of 2 months, he can go and eat the same food what he's eating before that. So the habit is very difficult to change. So typhoid vaccinations, at least, even though it is 70% to 85% effective, it is not 100% effective. It prevents complications. So give typhoid vaccinations. In fact, what we do, admitted hospitalized patients, when they go home, whether they're going to come back, I do not know. We put the typhoid vaccinations at the time of discharge itself, or a mandatory role we can give it. Similarly,
oral typhoid vaccine, you give?
No, oral typhoid is now not available. Only injectable typhoid. The combination conjugated vaccine is available. Previously, we used to give every 3 years booster dose. Now, typhoid conjugated vaccine is available. That is only 1 shot. So that will be effective. The cost is slightly high compared to the previous vaccinations. So we can give, whether we do not know whether the patient is going to come back to me, at least some benefit he can get by taking the vaccinations. Similarly, when the patient has got flu-like illness, influenza A is there, influenza B, lot of strains are there. If the patient got one strain of flu, again is going to get another flu strain is possible. So what we need to do, injection flu vaccine need to be given. Similarly, elderly people, they got flu or pneumonia-like picture. Again, within 2-3 months later, they can get again the pneumonia. So pneumococcal vaccines is needed for this type of patients. So one of the common advice what we are missing after treating fever, we are not thinking about preventing infections. Similarly, for urinary tract infections, for elderly women, particularly postmenopausal women, after treating UTI, they're known to get second infections, third infection is possible. One sugar control is needed, that's fine. Apart from the sugar control, they lack estrogen support. So we need to give estrogen cream to the vaginal region to prevent the recurrent infections. Similarly, cranberry juice, if they're not diabetic, it has got very minimal role. The data is a not strong one.
One more, Suresh, one more important advice. Abstain sex for at least a week.
Usually for young people, it might become very difficult, sir. But what we can say, these things has got proven roles, scientific roles there. For example, cranberry juices, estrogen creams, taking 2.5 liters to 3 liters of water, particularly during the summer, what you're having 47 degree, definitely this help urinary tract infection.
You have not answered my question. Urinary infection for a male or a female, sex can be advised or not for at least 1 week.
Usually, there is no scientific evidence I came across to avoid sex, sir. But after the sex, you can wash your genitals. It's more important. But avoiding sex, I don't think so.
Ravindra, what is your opinion?
No, sir. I do personal hygiene. That's all. I would not say that you should not have sex within a week.
No. Okay, fine. I think if there are any chat box question which you have not answered, we can answer because so far I have asked more questions. Any chat box questions which are not answered, Suresh, you are answering all questions.
I think you have answered, and Dr. Paniraman, a pediatric friend from mine from Dindivanam, is also answering for some of the pediatric related as well as adult related. He answered appropriately, sir. Most of the things, so I don't think so.
Any question in the chat box remaining?
Sir, Dr. Suresh has answered everything. A couple I answered, so I will not take much credit, but Dr. Suresh has answered everything and nothing is remaining. We discussed when you were not there, we discussed a couple of questions, sir, at that time also.
So you are saying indirectly my absence is better than presence, right?
No, your absence we utilize. We utilize your absence.
Yes, sir has got immediately responded, sir. That's very good. He thought 1 minute we are struggling there what to do, but Anupam sir stepped in immediately there. That's
we snatched the opportunity, sir.
Okay, fine. Now I think before we wind up, normally I do this. Vinita, one message for all our audience, one drive home message from your side.
diagnostic stewardship should be the emphasis. I mean, and keep that in mind that no test is perfect. Don't depend totally on the test. Keep the epidemiology and the patient's history and the background information solid so that we can interpret the report better in light of those factors.
Okay. Thank you. Ravindra, your message.
Use antibiotics. Please don't abuse them. Number one. Number two, use antibiotics in correct situations. Thank you.
Anupam?
Sir, fever needs to be carefully treated with a good clinical acumen, and we need to take care of fever individually. So, an individual case will need an individual approach for management. And definitely, the ancillary measures to treat fever are very, very important whenever managing a case of fever.
Good. Suresh, your final comment.
Sir, Krishna Kumar wanted to show Naga some slides before wind up because he wanted me there. Whatever we discussed, only I'm showing there. So this is a take-home message for me. So if you see, I think, sorry. So this is a difference. The differences between a good clinicians and indifferent clinicians is a time spent on history taking. And most of the time, the patient is giving history.
Put it on slideshow, Dr. Suresh. Please put it on slideshow.
Sorry, sir. Really sorry.
I'm happy to see even now 2,900 doctors are still watching in spite of the time is 10:15. They sacrifice the dinner. Maybe they're taking dinner and then watching.
Yes, sir. I put in the show now. Yeah. So this is the thing that the differences between a good clinicians and indifferent clinician is the amount of time we spent on history taking for fever, and real time patient is giving history. We are focusing somewhere. And this is an ordinary history. Suppose a patient came from, this is a history I got it. When a patient visited African country, Togo, he came to me with fever. So this is a common history taking. But how the infectious disease history, this is how we need to take. What he did in Togo, what he ate food, what sort of environment he stayed there. Then before coming to our own place, what are the things he did? So this is a detailed history we call. This is called the CID history. How the CID is digging the history from the criminals. We need to dig the history from the patients to find out the history. That's why instead of called ID history, this is called the CID history. We can call it there. And similarly, this is a head-to-toe examination. We already discussed about it. See the head-to-toe examination. This is most important thing. Unless we look at the hidden areas, we are not going to see this finding. See the hidden areas, get this hidden rule. That's called Jetty sign. And whenever fever comes, 3 to 5 days. This is a good paper from Chennai. It showed 250 patients they analyzed. 3 to 5 days, no investigations. Fever settles, no diagnostic test, no antibiotics. More than 5 days, do some simple blood test. Try to localize the fever. Try to assess the sickness of the patients. Accordingly, start antibiotic. This is a golden algorithm for starting antibiotic, doing investigations also. And this is WHO says Vidal has got limited role. I'm not telling. WHO is telling Vidal has got very limited role. Vidal is a test of historical interest. And according to our 2010 National Drug Policy, empirical therapy or presumptive therapy of chloroquine is not recommended. They want to make malaria as a different diagnosis. This is National Policy of 2010. Presumptive therapy is outdated. So presumptive antimicrobial therapy is also not good. Always make different diagnosis. When to test, 0 to 3 days, no test. 3 to 5 days, some basic test. More than 5 to 7 days, depending upon the flu, depending upon the antibiotics. And how to interpret common tests. Malaria, what is a good test? Peripheral smear or MPQBC. Typhoid, eosinopenia or culture. What test should not do? Vidal. Scrub typhus, history taking is good. Don't rely on scrub typhus IgM. So we need to know what test and what not test to do there. And finally, if you want to get any second opinion on fever, this QR code, please keep it, scan it, and send the QR code fill questions. We'll answer it to you there. As Fever Foundation part, we can provide this one. And thanks for the wonderful opportunity, sir. Thanks. And I thank my co-panelists. Beautifully, they did the job for me. So it is a job so that leisure time I can try to answer the questions. Thanks for the opportunity there.
Suresh, you made my job easy. Actually, I have noted all these points to give the conclusion. So you have
Krishna Kumar only wanted to make me the thing. That's why I did that. Thanks to Krishna Kumar.
You can now stop sharing.
Yes, sir.
Krishna,
sure, sir.
Krishna, stop sharing. Yes. Stop sharing, Krishna.
1 second, sir. Stop there. Yes, sir.
Okay, I think it was a wonderful discussion. I think I should first thank all the panelists from Ravindra, Suresh, Anupam, and of course, Vinita is new to me. And thank you very much for joining and answering all questions. Of course, I asked questions all over, from the investigation to patient education. My final message is, you will have to have a good communication with the patient. First of all, you should do patient education. Apart from history and all that, you must, educate the patient what to do, what not to do. Also, ask them to report properly. Sometimes, they come first day, then after 7 days they come. So good follow-up are also important. And hydration is very important. All the other points Suresh have summarized. So I think thanks Manjula, thanks Jairaj, Praveen Singh. Normally when we do such program, we get good dinner from Jairaj. Today, no dinner, no memento, no compliments. See, for example, Ravindra could not resist. He went to bathroom twice. No, he was there 2.5 hours here. So we are sitting like.
So we lost your voice.
Yeah. Sir, we lost your voice, sir.
The meeting that he is sitting, yes.
Thank you.
Yeah, correct.
That is what I was telling them.
Yeah, all the panelists are also saying that, instead of me, everybody is saying. So now, Jairaj and Manjula, please answer my questions. Well, I've already asked everyone questions. Now, Praveen, Jairaj and Manjula, my question, one is come out with the book, small dosage book. That's one thing I want to do. The second, Jairaj, I already requested for Physician Research Foundation, small book for the API conference. And third, of course, dinner and memento, and possible something more you can give. That's all. That's all from my end. Over to you, Jairaj, for your final comments, and Manjula.
Thank you, sir. Really, it was a wonderful session, and thanks each of our panelists for sharing their expertise and making it really very insightful and informative session. And you can see it was very interactive as well. We saw a lot of questions coming in. Thanks for the panelists to answering them also, and I think a lot of hard work went behind this from all of you all. And Muruganathan sir, yours also to collect everything and making it so effortless. So once again, thank you all for your time, effort, and expertise. Then over to Mr. Jairaj and Praveen Singh for the official.
Absolutely, it's a very fantastic interaction from everyone, and particularly I like the idea of answering the doctors in the chat box then and there, rather than waiting for the meeting to end and then answer.
Why, Jairaj? Because we won't have time. That is why then and there is answering is good.
Yeah. Once again, I thank all the panelists and the moderator.
Wonderful session conducted by Dr. Muruganathan, sir. We should give him a big hand.
Very good. I'm sure it's a very good knowledge sharing session for all the doctors who are present as the delegates. And once again, sir, thanks a lot for everybody and for sparing your time. And
Jairaj, you did not answer my question, Jairaj. Still have, Suresh is also waiting eagerly.
Offline,
is also waiting.
Offline, sir, we'll take it up because that is
offline. Okay, offline. We'll get Anupam. We'll get a pleasant call from Jairaj, Suresh also offline. So because we cannot openly say, there are so many restrictions now. So thank you very much, Jairaj, for.
Thank you, sir. Good night.
Thank you, sir.
Good night. Good night.
Thank you so much.
Thank you all.
Thank you, sir. Thank you.
Very good, sir.
So can we go offline, sir?
Yes, please.
Yeah, we can go off.